So if you're just joining us, we just need another minute, and then we will start. We are just waiting for people to join us in the webinar and the other various social media channels that we are streaming through. So just give us a moment, please. Thank you. Oops, another 30 seconds. Okay, just give us another couple seconds and we'll get going. We're just waiting for 9 o'clock on the West Coast. Yeah. Okay, I think we're going to get going. Hi, my name is Sam Guild. I am the president of AIM at Skin Cancer. I want to welcome everybody to today's educational event for patients and loved ones who have questions about non-melanoma skin cancer. First, I want to thank Dr. Sue Park from UCSD. Not only is she a phenomenal doctor, but she's also a good friend of mine. So I'm really excited today to be hosting this event with UCSD and all of the other providers from the Cancer Center who will be joining us today. So this event is going to be live streamed via Zoom, our Facebook pages, not just AIM at Skin Cancer, but AIM at Melanoma, as well as both of the organization's YouTube channel. We know there are going to be questions throughout today's event. If you are joining us via Zoom, I really want to encourage you to put those questions into the Q&A section. We understand everybody's eager to share and give shout outs and stuff, but the questions are going to be taken from the Zoom Q&A. On Facebook and YouTube, if you're joining us there, please go ahead, put your questions into the comment sections, and we will make sure that our moderator, Dr. Park, and all of our other guests from UCSD will see those questions. So without any further delay, Dr. Park, Sue, why don't we get going this morning?
Thanks so much, Sam. I'm really excited for the content we're about to deliver, and I'm really glad that you're all able to join us. So with that said, I'll kick it off, and I'm going to introduce our first speaker, Dr. Jennifer Lin. Dr. Lin is a dermatologist here at UCSD, and she's the director of the Melanoma Risk and Detection Clinic in the Department of Dermatology. She is also the dermatology lead for our cutaneous oncology program. And with that said, Jen, I'll let you take it away.
Thank you, Dr. Park. We're all really excited to be here. I think information is powerful, and that's really our goal is to give you the tools that you can use to best protect yourself. And so my talk is specifically about how our skin ages and turns into early skin cancer and how we can prevent that. Here are some of my disclosures. And we will move through quite a few topics. So the first one is specifically about the sun's ultraviolet radiation, how that contributes to aging and formation of skin cancer. And the second part is on how, given that, how we can prevent the damage. We'll talk briefly about early intervention. So when we see early skin cancer, what options do we have? And finally, we'll mention more severe cases where somebody has multiple early skin cancers and what options there are there. So we'll start off with giving you a look at the skin because it is more than one layer. And I hope everyone can see my arrow here, but showing this light, crusty skin, which is what the scale of your skin is. And the top layer is the epidermis, which is made of these keratinocytes. So the majority of these cells are what turn into keratinocyte skin cancers that some of my colleagues will discuss. And then below is the all the elastic fibers that give you tension to your skin. The major component is actually collagen, and this is also where your nerve bundles and blood vessels live. And this is relevant because skin cancer can only cause invasion or travel if it gets to this point. So I think we're all really familiar with what aged skin looks like. Most of us notice that there's a lot more laxity, that you can pinch up your skin. It doesn't stay taut to the rest of your muscles and bones. And that is largely due to a loss in collagen over time. The epidermis also gets thinner, and so the vessels underneath become more visible and easier to bruise because they're not cushioned in that soft layer anymore. We often see increased pigmentation, so those are due to changes from the sun. And then the skin quality can change too. So we understand now that over time the skin will naturally age. And so we call this intrinsic factors of aging. These are things that we really can't control. There's this concept that of senescence, which means that all cells in our body are destined to end at some point. It's actually determined by the length of the telomeres. So over time, eventually the cells don't grow as robustly and we get less skin turnover, not as good wound healing. We don't produce as much collagen. We lose our hormones, and all this contributes to older skin. One of the things I wanted to point out on this schema, though, is how nice and ridged this younger skin is. Most of the stem cells are thought to be harbored at the base of these reedy, what we call ridges. And you can see how that kind of flattens out over time. And this is, again, the histologic view of showing how the skin over time does change. And we lose that nice reedy ridge. These vessels are more dilated. And if we did a stain, we would see that there's a lot less elastic fiber. But what are the things that we can control? And we would call these extrinsic factors of aging. The number one problem for skin is ultraviolet radiation. There's some studies that suggest that 90% of aging of the skin beyond intrinsic factors is from ultraviolet radiation. There are probably other multiple factors, some which we haven't fully identified yet. But we certainly know that smoking, radiation, those things can also cause DNA damage. So why is causing DNA damage relevant to skin cancer formation? So in general, our cells are, as we grow older, surviving on onslaughts to our DNA, and our DNA is how we replicate each cell faithfully so that it comes out the same every time. But if the DNA gets damaged, then your cells are still pretty smart. They can repair it, or they can choose to basically suicide and die. But in that case, the cell is eliminated. The major problem actually is, that's to make sure everyone's still awake, is when a mutation forms. So a mutation means that the DNA is now altered irrevocably, so that mutation will be passed on every generation. And this usually is the beginning of cancer formation. I highlighted this gene called P53. It's often called the guardian of the genome. And it's one of the last steps that we lose when we're forming cancer. So it's a really important gene that helps us repair our DNA, or if we need to get rid of the cell completely. When we think about what hits us from the sun, it's important to remember that there's actually many wavelengths that are hitting us. And we are mostly focused on ultraviolet radiation. Interestingly, UVC is the most DNA damaging, but that is largely filtered out by the ozone layer. There are certain pockets where the ozone layer is a little bit more broken up, namely over Australia. And it is probably not by accident that the only two countries that have a higher rate of melanoma than the US is Australia and New Zealand. But UVA actually constitutes the majority of the rays that hit us, but we're very focused on UVB when we're talking about protection, largely because most of the studies were done on this, but you should be blocking against both. And there are differences between these different ultraviolet radiations. One of the most important differences is that UVA can penetrate a little bit more deeply than UVB. And one thing we try to remember is UVA for aging. So because it penetrates deeper where the collagen is, it probably depletes collagen a little bit faster. So UVB, again, there's been a lot of studies done on how it alters DNA. And one of the ways it does is by forming these thymine dimers. And so I think you can appreciate that it causes these bonding between the thymine bases, and it actually introduces a new nucleotide, which permanently alters the DNA. So, what does your body do when it gets assaulted by ultraviolet radiation? Well, it draws on this cell called the melanocyte to make pigment, and that's how we tan. And so, tanning is largely felt to be protective if you can tan. So, why do we talk about sunscreen so much? Because it is our main form of primary prevention. It has been shown to prevent skin cancer, and our best study comes out of Australia. It's a randomized control study, and the two arms were you had to put it on every day to your face and your hands, or you could put it on if you felt like it. And there was a clear benefit from the individuals who put it on every day. They did a very long follow-up, which is what you need to do when you're tracking skin cancer. And there was a 50% reduction in new melanomas and also a reduction in squamous cell. So prevention strategies, there are many out there. Some of the ones I like to reinforce the most is it wears off, so you need to reapply. Probably every 2 hours, I have people set it on their phones to ding them. The sun does alter in its strength over the day, and you can always set up a UV index calculator on your phone, but generally the midday is the strongest sun. Protective clothing and avoidance is always going to beat sunscreen, so that's always an excellent option. And this was a mnemonic that came out: slip, slop, slap, seek, slide, to remind you of the different ways you can protect against the sun. And probably a combination of all of these is extremely useful. Okay. Oops. Shade is wonderful. So a lot of patients ask me, well, if I'm at the beach and I'm under umbrella, do I still need to wear sunscreen? And there was a study that looked at this, and the answer is still you should be wearing sunscreen because it does reflect off the water and the sand. Oops, excuse me. Let me just get back to that picture. So about 70% of the rays are still going to be coming through. There are two major forms of sunscreen currently in the US market: physical sunscreens, which work by reflecting ultraviolet radiation, and chemical sunscreens, which work by absorbing the radiation and quenching the free radicals. But once it takes the hit, it's used up. So your sunscreen is being used up while you're standing out in the sun. And they do block, if it says broad spectrum, it does block against both UVA and UVB. I actually prefer the way Europe and Asia measures it. They have separate measurements for UVA and UVB, but we don't have that in the US, so you should be looking for a broad spectrum. And does it really matter the degree of your SPF? It actually does, because it's measured on how many ultraviolet how many free radicals it quenches. But this is a real life study where they took a bunch of skiers in Vail, and they asked them to put an SPF of 100 on one half of their face and SPF 50 on the other half. And then the following day, after about 6 hours of skiing, they examined if they had a sunburn. And the individuals who were using the SPF 50 had more sunburn on their SPF 50 side. There were some individuals that didn't see any difference, but there clearly was a benefit to using the higher sunscreen. So my general recommendation is for daily use, where you're mostly going in and out of, offices and, shopping, but you're not actually sitting outside. An SPF of 30 for your daily wear is sufficient. But the minute you are choosing to do an activity that's more than 2 hours outdoors, you should be adding on a higher SPF. So this is a nice example of those thymine dimers that I was showing you earlier that is caused by UVB radiation. And you can see that on normal skin that after exposure to the sun, you form all these dimers and you see how they grow out because after 72 hours, because the damaged cells, the epidermis does renew itself every 2 weeks. And you can also see that with even an SPF of 15, that the cells were not damaged and did not form thymine dimers. So it is effective in preventing the direct DNA damage. And if I can't convince you to prevent against skin cancer, then certainly it is also preventing against photoaging. And this is a classic example that's often shown in medical school to illustrate a truck driver. So you can see that many of the changes we see are from cumulative sun over time, and the left side of their face really shows that leathery change from years of driving in the truck. I wanted to briefly explain, though, that not every skin is the same. And when we're tailoring our protection message, that we are taking into account your specific skin phototype. So the skin phototype was developed by Dr. Fitzpatrick in Boston to determine the risk of someone's skin cancer risk. Dr. Park, do you know how much time I have? Because I didn't actually set it on my phone, the 20 minutes.
I believe you have 15 minutes
Left?
because I think we started a little early.
Okay, perfect. Okay, just wanted to make sure. So the skin phototype ranges from 1 to 6. Um, and 1 to 3 is largely felt to be individuals who don't have much pigment at baseline. And then as you move from 1 to 3, more tanning ability occurs. Whereas from 4 to 6, the individuals have some pigment and melanin at baseline, and they always can tan when they get exposed to the sun. It's not a perfect schema, and there's clearly so much intermixing that we can't just use these categories, but they are loosely useful to determine someone's risk. And I think the best example of why this is useful, oh, sorry, these are the terms that we use to describe the different pigment we can get. Um, but the best, oh, and then the different types of reactions we can have for anybody is you either burn or you tan. And this original schema was very specific. If you're standing out in Boston, which is a higher latitude than we are here, for 30 minutes, do you burn or do you tan, or do you burn first and then you tan? So those questions are all relevant in how we determine someone's skin phototype. So the most interesting or most stark example in this group is the redhead. So these are skin phototype 1. They actually, we know many mutations in this very large gene, which leads to this reddish color, blue eyes, usually very fair skin, and some freckling as well. Interestingly, it's a very well conserved mutation, so there's clearly some benefits from this. They've actually genotyped the woolly mammoth and other variations of skin coloring. They all carry the same mutation or variation, I should say. But the red hair phenotype is our most extreme example of who's at risk of skin cancer. And because we have 2 copies of genes, most blondes also have at least one of these alleles. And even around 20% of individuals who have black brown hair, but are very light and burn easily, also carry one of these. And the difference is that these individuals are at higher risk of developing melanoma, so 1.5 to 4 times, increased risk of basal cell, about 2 times, and increased risk of squamous cell, so about 3 times. So indeed, these individuals, because of their ability to form, so these patients can't tan at all, they're at higher risk when they get exposed to ultraviolet radiation. So these are the patients we need to protect the most. So if you baseline have some pigment in your skin, is that protective? For sure it is, and probably at a level that we it isn't determined just by the color itself. So if we look and quantify how much pigment is actually between someone who has very dark skin, someone very light skin, it's only about twofold. And maybe we measure an SPF of 3, but the risk drops, 25 to 68 times. So if you have melanin in your skin at baseline, your risk of skin cancer is a lot lower. We probably don't need to protect you from the UV radiation quite as much. And this is a nice example of how pigment in your skin blocks against DNA damage. Again, so this is normal skin after radiation from the sun. You can see those thymine dimers forming only in the epidermis, but also in the dermis. And this individual has pigment in their skin. It doesn't even get to the dermis. So there is protection. And again, this is really seen also, this is SEER data from the USA, that the number of skin cancer formation is just a lot less. Okay, so how do we prevent? So number one is, I just told you that UV is the main cause of most skin cancer. So you either avoid it or you block against it. And we talked about sunscreen already. We talked about UPF clothing. We talked about hats and sunglasses. Secondary prevention is trickier and is an area of active research, which is this idea that after you've already been exposed, can you reduce the impact of that injury? Can we improve repair of DNA? Can we improve your immune system to come and clear out those mutated cells? So this is a really active area of research. So I want to talk a little bit about this concept of antioxidants. We naturally have them in our skin, and vitamin C is one of the main ones that are in our skin. There's also alpha tocopherol, which is a variation. I think it's another very close, very similarly related to vitamin C, and ubiquinol. There's also glutathione. I don't have that on this slide. Okay. Oops. Oh, there it is. Okay. So vitamin C, lots of people have been interested in that. They've done studies on it, and the main studies have been showing, here is vitamin C and E together, and this is showing again the thymine dimers, and you can see that the pig skin that had vitamin C and E in their skin didn't get as much damage. And more elegant studies have been done on this in mice as well. So the winner in these 3 different types of topicals was actually vitamin C and ferulic acid, which is here, this last column here. So this had the least amount of DNA damage when you put this on the skin. So I do recommend topical vitamin C underneath your sunscreen, especially if you're going to be out in the sun, as a way of reducing further damage. Okay, so it's a little bit more detail on that. There also have been studies on oral intake of antioxidants, and these are, again, pretty hard studies to do because you have to follow these patients for a long time. They usually are reporting what they've been taking, but it did seem overall that consumption of lutein and zeaxanthine, which is found in green leafy vegetables, decreased squamous cell. And the vitamin E story has been kind of interesting. Even from the topical point of view, I actually removed one slide, but vitamin E alone isn't helpful against blocking DNA damage. And from a dietary standpoint, it also wasn't hugely helpful. And it's not to say that you should try to remove it from your diet, but just interesting that, that's a vitamin that has been tested in many types of prevention studies, such as for cardiac, but hasn't really for skin borne out to be that useful. Heliocare is a plant-based, it's actually the fern plant. You can buy it as a supplementation. Its main benefit is reducing sunburn, but it hasn't been carefully studied to show whether it prevents skin cancer. I do use it in conjunction. I have some patients who are very sensitive to sunscreen, so they can't tolerate traditional sunscreen, and they want to have some sort of protection. I also have patients who own boats or are just out all the time that I find that this gives them a little extra protection. But the newest kid on the block, which is very promising, is actually oral nicotinamide. So this is vitamin B3. The dosing that was studied in a pretty rigorous study was 500 milligrams twice a day. And in that study, these were high-risk individuals who formed more than 5 basal cells a year. These individuals noticed a 20% decrease after 1 year of taking this vitamin. It doesn't reduce skin sunburn. And there's also just a really large retrospective study that came out of the VA that also showed a benefit, particularly after they were diagnosed with their first skin cancer. There has been a theoretical concern that nicotinamide can be changed to niacin, which is used to be a cardiac medication, but has been removed from the market because it doesn't help, and in fact may increase mortality. But there have been several studies now showing that that risk is probably really low. There's probably a genetic group that may carry this risk. But overall, so I do check just to make sure my patient doesn't have a strong cardiac history, meaning they have multiple family members who had heart attacks in their 40s or very early strokes. Um, we don't currently have a genetic test, but beyond that, I'm pretty comfortable giving out this supplement. Early intervention. So I mentioned again that the main issue with UV damage is it leads to mutations. And actually, before it becomes cancer, it's precancer first. And I'm going to be talking about the keratinocyte precancers because that is the major cell type that makes our skin. This is the most common precancer that we see. And these are usually called actinic keratoses. They're typically pretty gritty. You can feel them almost better than you can see. Some people complain that they're blotchy and red and also feel roughness. So that's going to be your actinic keratosis. And this is thought to be a precursor to squamous cell. And here's a diagram again showing how the cell eventually loses P53. It can't control its growth regulation anymore and it starts to proliferate. But the conversion rate to cutaneous squamous cell is thought to be pretty low. I was taught 7% when I was training. There are many studies that show 0.5% to 20%. So it's very hard to study this formally. Nonetheless, when we see that, we try to treat it. But I would say that there are many patients who live their whole lives with this and are not caused any undue harm from it. So I think of them more as weeds than something that's causing a lot of concern. But we also have a lot of treatment options. So of course, as I mentioned, the primary and secondary prevention of sun protection, and now I'm adding on nicotinamide. But you can treat them topically with topical antimetabolites, which is a topical chemo. Um, so Effudex is going to be the main one you're going to hear about. I'm not going to go in great detail to these topicals because Dr. Dang is going to go into more detail about them. So I'm just mentioning that the same creams for basal cells are available for these actinic keratoses. Um, we also have this immune boosting one called imiquimod or Aldara. And this is the newest kid on the block that doesn't cause as much inflammation, but is also stopping growth. We also have destructive methods. So the most common thing probably your dermatologist will reach for is cryotherapy or cryosurgery. Many of the laser destructive methods are very useful if someone has multiple lesions all over their face. And photodynamic therapy, which again, I'm not going to go into detail here, is also very useful when it's covering a large area. Effudex gets a lot of press. So a lot of my patients go on the web and are like, I am not doing that topical. And this is an example of why someone wouldn't after seeing these photos of how red and inflamed you can get. We do have the opportunity to titrate how much you're actually putting on, so you don't need to get to this level to have an effect. I'm happy with here. And there are ways of kind of mitigating that. The main one has been adding on calcipotriene along with 5-FU. Okay. And I just want to show that you do heal and you eventually have much smoother skin, even despite how awful you look during treatment. So again, why treat them? Well, there are some lines of evidence that show if you treat them, you have less skin cancer risk. And again, I just wanted to point out the caveat that actinic keratoses can also spontaneously disappear and reappear on its own, depending on how well your immune system is working to get rid of them. Um, and so again, I think of them as weeds, but then my main message is don't water or fertilize your weeds. Don't go in the sun because you're only gonna add to that. Chemo prevention is a very different angle, and we reserve this really for our patients who their immune system, for whatever reason, is not up to snuff and not working well enough to remove the skin cancer on their own. And again, I'm really talking about squamous cell in this case, which is heavily regulated by your immune system. So this is an example of a patient who is a lung transplant patient and so has to go on immunosuppressive regimen in order to protect their new lung. But as a result, their immune system cannot fight against the skin cancer efficiently, and they're just covered in lesions. Um, so again, when we think about this, though, there are probably other individuals who don't necessarily have taking all these medications that could still benefit from chemo prevention. So I think of individuals who are making more than five of these non-melanoma skin cancers per year, um, strong family history, developing skin cancer very early on in their life. So there are probably other individuals who are higher risk that could benefit as well. And I'm almost out of time. So I'm going to talk quickly about the two different medications. So one is acitretin, which is a cousin of Accutane that you probably have heard about for acne. It also works by causing the keratinocytes to mature and differentiate, which is helpful in acne. It happens to be helpful in skin cancer because, as I mentioned, those mutated cells end up growing up a little bit more normally, and that will decrease. So this was one of the most, that's my timer, one of the most recent studies showing that in a transplant patient who was on acitretin, the number of squamous cells really did drop. And then I want to talk briefly about capecitabine, which is a prodrug for 5-fluorouracil. That's the drug that when topically is called Effidex. So this medication can be given orally to a patient. And this had a really good effect again on the squamous cell rate in these high-risk patients. There's 80% response rate. Only 3 out of 15 in this particular study did not decrease the amount of squamous cell. And I just want to show you this dramatic photo from one of my colleagues back in Boston, someone who's getting a lot of surgery, who really cleared up really nicely, and a separate patient, numerous lesions on their legs, who again really had a benefit and decreased the amount of surgery that they needed. So I apologize, I need to stop, but again, the main message is there's a reason why we harp so much about using sunscreen. There are more secondary preventions coming out, such as oral nicotinamide. We do tend to treat early skin cancers, such as actinic keratoses, but in general, not something to be nervous about because it's a very low risk lesion. And then chemo prevention can be important for our higher risk patients. Thank you. I left my email here as well if there's any questions.
Thank you so much, Dr. Lin. That was such a great overview. And I'd like to introduce our next speaker, Dr. Veronica Shi. Dr. Shi is a dermatologist here at UCSD, and she'll be talking to us about skin cancer risk stratification.
Thank you, Dr. Park. It's great to be here this morning. Let me just pull my slides up. Okay, hopefully you guys can all see that. So I'm going to be talking to you about skin cancer risk stratification. Basically, what that means is, we'll go over the different types of skin cancer and then what makes a skin cancer lower risk or higher risk. So to start, we'll just do a brief background about skin cancer. We've heard a little bit already from Dr. Lin, so I won't spend too much time on that. But we'll go over the main types of non-melanoma skin cancer, and then we'll dive into details about, again, what makes something lower risk all the way up to very high risk. So just for some background, skin cancer is the most common cancer in the United States. So if you look at all of the cases of any type of cancer combined, skin cancer still is much more than that. So this data is a little bit outdated, but it's still actually some of the best representation of the numbers. So back in 2013, there were over 5 million cases of non-melanoma skin cancers. So it's very common. About 1 in 5 Americans will develop skin cancer at some point during their lifetime. So it is, extremely prevalent. And the vast majority of these skin cancers are going to be non-melanoma skin cancers. So it's about 95%. Of non-melanoma skin cancers, there's two types. And so basal cell carcinomas are the most common type. And there's over, almost about 3.5 million new cases each year in this country. Squamous cell cancers are also very common. It's the second most common type, and there's almost 2 million cases of this each year in the United States. So again, very common, and lots of people have personal experience with these skin cancers. So we'll start with talking about basal cell cancer. You will often see this abbreviated as BCC. Basal cell cancer is exactly the same as basal cell carcinoma, which is kind of the more technical term for it. Again, like I just mentioned, most common skin cancer you're going to see. The typical risk factors are going to be lighter skin type. So fair skin, light hair, you're going to be higher risk for developing BCCs. Typically with older age, that's also a risk factor. And we think that that's primarily because, a very strong risk factor for BCC development is cumulative sun exposure. So just like Dr. Lin was talking about, the more kind of chronic UV exposure that you've had, which kind of makes sense as you get older, you're going to accumulate more of that. Your likelihood or chance of getting a BCC is going to be higher. Usually, the way these present, what you might want to look for is typically a pink spot, although that's not always the case. They can be kind of darker in color, almost brown, almost black sometimes in some patients. So depending on certain skin types, there can be color to them. But typically they're sometimes skin colored or almost, pink color. They tend to be mostly in sun exposed areas. So those are going to be areas like your face, your neck, scalp sometimes, top of the forearms or the back of the forearms. And often they can have easy bleeding. So, if there's ever a spot that bleeds really easily, even without scratching, without injuring it, it just bleeds on its own, that can be kind of a suspicious feature that it's possibly a basal cell cancer. Overall, though, the prognosis is really excellent. So it has an excellent outcome the vast majority of the time. They're very easily treatable. There are reports of metastasis, which is essentially, spread inside your body. They're very, very rare. So really, the vast majority of these cases do not spread or do not metastasize. And the prognosis is based on the subtype of basal cell cancer. So we'll get into that in a couple seconds. But there are different subtypes, and this is going to be something that you won't really know the subtype until you actually go in and see your dermatologist and they do a biopsy. It's typically only something that you can confirm under the microscope with a biopsy. In general, most of the main issues that come from basal cell cancers they're just going to stem from the fact that if untreated, they're going to get bigger slowly over time. They're going to grow in size, and then they might cause issues in that area where it's growing. So it's going to kind of destroy the skin and, maybe some of the body structures in that area where it's growing. But again, it generally does not spread inside your body. So these are the subtypes of basal cell cancer. And again, this is very technical. This is something that you might see if you have access to your biopsy reports. So if you see any of these terms, hopefully this is a little helpful in terms of how to characterize these into lower risk groups or higher risk groups. So the two most common subtypes of basal cell cancer are going to be superficial or nodular. We see these really commonly. It's the two most common types. These are both low risk. So if you see this term anywhere, you can feel a little more reassured. These are really common to get. If you see any of these words on the right, so for instance, infiltrative or micronodular, those are going to be higher risk. All that means, without getting into too much technical detail, is basically that this cancer cells are a little bit deeper into the skin. They're kind of a little bit more infiltrative, and they can tend to be a little bit more aggressive, just meaning they might go deeper into the skin. The skin cancer could be wider or deeper than what it looks like on the surface. Morpheoform is another higher risk type. It's really not all that common, but you might see that every once in a while. And the photos again just represent that this is something that really only your pathologist is going to make this diagnosis. So you wouldn't really be able to tell this looking at the spot, but you just have to go and see your dermatologist and have them do a biopsy. So there are different body sites that have slightly different risk levels. And so essentially the lower risk sites are shown on the right figure in gray, and that's going to be the majority of your body. So primarily, most of your trunk, your arms, and most of your legs. The idea here is just that these areas, there's more real estate to that area. There's more skin. There's usually, a bit more stretch to the skin. If you end up needing some sort of treatment, for instance, surgery, it's much easier to perform a surgical treatment where there's a little bit more skin there in that area. So the next level up, medium risk sites, are shown in green in the diagram. So those are going to be areas like parts of your face, so the cheeks, the forehead, the entire scalp, the neck, and then also the front part of your shins. And so the idea here is that, there's still generally skin and space there, but it's starting to get a little bit tighter. There's not as much skin to go around. And so it just makes treatment potentially, more difficult. And then higher risk areas are going to be areas in the central face. So areas like the eyelids, the nose, the lips, and the ears. That makes sense because, there's just not a lot of skin there. There's a lot of important structures in those areas, like your eyelids, your mouth. And so those are going to be higher risk sites. There's also a slightly higher chance that, the skin cancer potentially could spread from those original areas. Other high risk areas include the hands, the feet, and the genital area. So we'll talk a little bit about squamous cell cancer next. Basically, there's two different types of squamous cell cancer. So you may see some of these terms, either in a biopsy report, office visit note. So the first type, in situ, refers to the fact that the cancer cells are only in the top layer of skin. The second type, which is invasive squamous cell carcinoma, just means that now the cancer cells are kind of invading a little bit deeper into the skin. So they're through that top layer of the skin, which is the epidermis. Sometimes you don't always see the term invasive. So if anything just says squamous cell carcinoma, it's kind of implied that it is the invasive type. You will always see the in situ type if it is referring just to to that more superficial or more kind of shallow involvement of squamous cell cancer. So the other, way you might see it is just completely abbreviated. So SCCIS stands for squamous cell cancer in situ. Again, common theme here, it's usually going to be more likely in lighter skin types. Sometimes specifically in the genital area, it can be related or associated to HPV infection, which is human papillomavirus. It's a very, very common virus. There's many types. It is a virus that sometimes can cause genital warts in that area, but occasionally it can also lead to the development of these very early types of squamous cell cancers. Typically what it looks like is, again, could be either pink or brown, like darker in color, depending on the skin type of the person. It's usually a bit scaly, can be flaky. Usually there's a little bit of kind of texture on the surface, so it's a little bit raised. You might be able to feel a bit of substance there. But these are again have a very excellent prognosis. They're really not very aggressive. They tend to grow very slowly, and they usually do just stay mostly on the surface of the skin. So they tend to get wider instead of going deeper into the skin. Now, invasive squamous cell cancers are a little bit more aggressive. Risk factors are again going to include fair skin. Any history of tanning bed use can really significantly increase the risk. That just goes back to what we've been talking about this whole morning, where, increased UV exposure and damage can increase your risk. Just like Dr. Lin mentioned as well, if anybody has a weakened immune system, so for example, a lot of our transplant recipients, so people who have had an organ transplant, have very low weakened immune systems, that can really be a huge risk factor for squamous cell cancer development. And then other factors sometimes come into play. So areas of chronic ulcers or chronic burns and any area of the body that's had a prior history of radiation. Usually this is going to be a raised bump or almost like kind of a nodule, like a lump or a marble that you can feel. It's going to be raised from the skin. It can be kind of crusty, a little scaly, like it might have some scabs on the surface. Um, if this is an invasive squamous cell cancer, there is a higher risk of metastasis, which is spread, or potentially even death compared to basal cell cancer. So we do worry a bit more about these squamous cell cancers. And these are some of the main risk factors that can really kind of make the level of risk of a squamous cell cancer much higher. So these are things that you can either tell, from the spot itself, or they're going to be findings that you would only see again on a biopsy, so after you've seen your dermatologist. So typically, some of the risk factors are size, and so anything bigger than 2 centimeters, which is about 3/4 of an inch, just to kind of give you a reference point. And we're talking about kind of the diameter of what it looks like on your skin. Depth is going to be something that you can only really tell after you've had a biopsy. So that's how deep it goes into the skin. So, if it goes deeper all the way into the fat level of the skin or even deeper, potentially into the bone, that's going to be a worse prognosis. Certain locations, like we already kind of mentioned, like the lip, the ear, and the genital area are going to be higher risk. And then there's something called perineural invasion. So that's going to be something, again, you can only see on a biopsy report. Basically, what that means is the cancer cells are starting to wrap around or even invade into small nerves in the skin, and that's only something you'd see under the microscope. There's also something called poor differentiation. All that means is that something the pathologist is going to diagnose, and it just means that he or she is seeing really abnormal looking cells. They can sometimes look very strange. They can look very messy and disorganized when they're looking under the microscope, and that can be a worse indicator. And then again, anyone who has a weakened immune system is already going to be at higher risk. So, what do we actually mean when we're talking about risk? Essentially, it kind of breaks down into 3 main points. Why does risk matter? Essentially, risk is referring to the likelihood of a couple things. So, local recurrence, which just means that the skin cancer could come back in the same exact spot that it presented. And so, obviously we don't want that to happen. We want to make sure it's completely gone, but higher risk skin cancers could grow back in the same spot. There's also a chance of metastasis, and like I mentioned, that's distant spread inside the body. And obviously we don't want that to happen either, because that can lead to other issues with your organs. It can potentially even lead to death. And so we definitely want to reduce the chance of any sort of spread. And so risk is ultimately going to determine the appropriate treatment. So, a lot of times these skin cancers are treated with surgery, but we're going to hear from all the other doctors this morning about potentially other treatments that can be considered too for higher risk skin cancers. So this table just kind of summarizes everything we've talked about so far. Hopefully that's a helpful visual for some of you. And so low risk skin cancers are going to be small spots that are on a low risk body site and tend to be some of the superficial subtypes of either basal cell cancer or that squamous cell cancer in situ. We're going to hear from Dr. Dang about other non-surgical options to treat those. Most of the skin cancers we see are going to kind of fall into the moderate risk group. So again, usually smaller size, most body sites in a healthy person with no other major medical issues. And typically most of the time we treat these with surgery. So anything that has any of these features listed down below is going to be high risk. So a large size, that term poor differentiation, any involvement of nerves in the skin, certain body sites like the face, lip, ear, and again, anyone with a weakened immune system. If the skin cancer has multiple of these features, it's going to be very high risk. And usually in these cases, we're thinking about typically Mohs surgery, but potentially other treatments on top of that, including radiation and others. So essentially, when should you worry? I would say if there's anything that is, large, and the threshold we're talking about is usually about 3/4 of an inch or 2 centimeters. If anything is growing just really quickly, that's always something we worry about. If it's doubling in size, over the course of, a couple to a few weeks, that's definitely growing very rapidly. If there's any sort of pain, numbness, tingling in the area where that's growing, that might be something that, we would be worried about potential nerve involvement. And then certain areas like the face, lip, and ear, if it has any of these features above, just let your dermatologist know as soon as possible, and they will get you in to do a biopsy. So in conclusion, there are two main types of non-melanoma skin cancers, basal cell cancer and squamous cell cancer. The great news is that the vast majority of these are really easily treatable and really easily removed. There are certain things to watch for that can make skin cancers higher risk, including larger size, certain areas of the body like the face, lip, and ear, and really multiple features that we would only identify on a biopsy report after you've had that procedure done. So, in conclusion, reach out to your dermatologist. They're always the kind of the best person to start with if you have any questions about the type of skin cancer or kind of the risk level, and they can help answer any questions that you have. So, thank you for your attention.
Thank you much. Thank you so much, Dr. Sheed. That was excellent and a really great framework for some of the other talks that we'll be hearing. I do want to introduce our third speaker, Dr. Swati Cannon. So Dr. Cannon is a Mohs surgeon, but not only is she a Mohs surgeon, she's a cosmetic dermatologist. So I thought her next topic is very fitting. She'll be talking about surgery, healing, and scarring.
Thank you so much, Dr. Park and AIM at Melanoma for organizing this wonderful webinar. So we've already heard some great talks from Dr. Lin and Dr. Shi, and my presentation will kind of elaborate there. So I hope everyone can see this. I will be discussing kind of the two forms of skin
You can't see your
cancer.
presentation yet.
Oh, you can't? Okay. Well, that would be helpful if I shared the presentation, wouldn't it? Okay, here we go. Okay, is that better?
Yes, that's it. Thank you.
Perfect. So my presentation is on the two different surgical options for skin cancer surgery, and as well as how we can optimize healing and scarring. So Dr. Dang will discuss the non-surgical options, and what I mainly focus on in my practice is Mohs micrographic surgery and then what's called surgical excisions. So Mohs surgery is actually named after Frederick Mohs, who came up with how we process the tissue for Mohs, and I will review that in a minute. So it doesn't stand for anything, it's just named after Frederick Mohs. So Mohs surgery has one of the highest cure rates for skin cancer, so about 99% for a basal cell carcinoma, and about 97 to 99% for a squamous cell carcinoma. With the Mohs technique, we can also remove the least amount of healthy tissue. So meaning that we can clear the skin cancer without taking too much of your normal skin. And that usually means a smaller scar. We also have immediate confirmation that all of the skin cancer is gone before we stitch it up. So that means that you don't have to come back after the stitches are placed because we'll clear it before you go home. The downside of doing that is that you're in our office for a very long time. Mohs surgery is unique. We have patients, multiple patients kind of start at once, and you will be in our office from between 2 to approximately 6 hours as we're waiting for tissue to process. And so the question is, if Mohs is so highly curative, why can't we use it for all the skin cancers on all the different parts of the body? And the answer is it's just not always necessary to do Mohs on, for example, a small skin cancer on the back where we do have adequate tissue to be able to do a surgical excision. So there was criteria developed called the Mohs appropriate use criteria. And there's actually even an app that patients and doctors can use. And we first input what kind of skin cancer we have, which area of the body it's on, and then we'll also have inputs for the subtype of the skin cancer, and then we'll get the actual level. So if it's 7 and above, it means the Mohs is appropriate for this skin cancer. If it's 3 and below, Mohs is not appropriate, and 4, 5, and 6, where it means it's uncertain, so it's at the discretion of the surgeon. In general, though, we use Mohs surgery for skin cancers on areas where we don't have too much skin. So, for example, on the head, so face, nose, ears, eyelids, lips, neck, hands, feet, genitalia, tight areas on the body like the shins where that skin is right on top of the bone, it's very tight. So we want to be able to clear those skin cancers before we can do a complex closure. For most skin cancers, I would say, not any. For most skin cancers greater than 2 centimeters on any part of the body, we would do Mohs. For skin cancers in high-risk individuals, so these are immunosuppressed patients, whether they're immunosuppressed from having an organ transplant or from medications, HIV, certain leukemias. For skin cancers on these patients, we almost always will do Mohs regardless of the location. And then there are certain subtypes of skin cancers that Dr. Shi reviewed. So for example, an infiltrative basal cell carcinoma is an aggressive subtype. And so for that, we will usually do Mohs, or if it's a poorly differentiated squamous cell carcinoma, regardless of the location, we would usually do Mohs as long as it's greater than 1 centimeter. So how does this process actually work? So the medical dermatologist will do a biopsy. That biopsy would show, oh, hey, it's a skin cancer. And then they will put in a referral to somebody like me. When you come in to see me, everything is done under local anesthesia. So we don't put you to sleep, but we inject lidocaine. Similarly to how the biopsy was done, we inject lidocaine kind of in and around that biopsy site to completely numb the area. And then we take a first layer. So we take a very narrow margin around and under the tumor. My analogy that I use for this is imagine that you have a rotten portion of an apple. So you're not going to cut into the rotten portion of the apple. You're going to cut around and under it to remove it so that you still have that healthy rest of the healthy apple. And so that's exactly what we're doing. We're just taking a narrow margin of normal skin because we want to check the margins. If we cut into the tumor, our margins would obviously still be positive. Once we cut the first layer of tissue, the third part is that we actually divide it into sections. Sometimes we'll have it as 1 section, sometimes it's 2 sections, sometimes it's 4, 6. This number of sections depends on how big the tumor is. And then each section is actually going to be processed by a histotechnician. So we actually have a lab right within our Mohs suite, and we have histotechs who will process the tissue. The processing involves freezing the tissue, which takes time. The frozen tissue is then cut into very, very thin slices that are around 7 to 10 microns, so very thin. And then those slices are put onto a glass slide, and then those glass slides are stained. So that entire process to process the section takes about 30 to 45 minutes per section. And so that's why there's so much waiting period on when we do Mohs. Once the tissue is processed, somebody like me, or I'm the Mohs surgeon, we're also the pathologist. So we would then take a look at underneath the microscope. And we also have a map that coincides with what the tissue looks like under the microscope. So wherever we see the cancer cells under the microscope, we mark it on the map. So for example, if I see that it's positive between 3 and 6 o'clock, I will mark it between 3 and 6 o'clock on our map. And then I go back to the patient room, we numb the site up again with local anesthesia, and I cut more. And then the patient waits again. Finally, once the margins are completely clear, we decide that, are we going to stitch it? If so, what kind of reconstruction are we going to do? And this is usually a discussion between the surgeon and the patient. And in very few instances, we might work with another type of surgeon, like an oculoplastic surgeon or a facial plastic surgeon for the reconstruction. So let's look at the actual processing. I will try not to make this too heavy and try to easy to understand, but the Mohs technique is really more about how the tissue is processed. So when we have a standard excision, the pathology is different. The processing is different than when we do a Mohs section. So in standard pathology, the pathology lab will take the specimen and will cut the tissue into vertical slices, almost like slicing a bread loaf. And then some of these bread loaves are then examined by the pathologist for whether or not there are clear margins. So with this standard bread loafing technique, the entire specimen is not actually visualized. Whereas with the Mohs frozen section, the outer edge of the specimen is kind of flattened and then cut. So the entire section is actually examined as one continuous map, and we're able to check the margins in a 360-degree fashion. And so that's why the Mohs technique has a higher cure rate than the standard excision technique. The most common question I get before we even start Mohs is, how many stitches are you going to place, doc? And to be honest, that number is very variable. It's variable on the location, on the size of your skin cancer, and also on the surgeon. Some surgeons will just place a greater number of stitches than others. So here we have what's called a linear closure. So there was a skin cancer right here in the middle, and we were able to stitch it up kind of in this curved linear fashion. But sometimes we have to do what's called a skin graft, meaning we have to take skin from somewhere else and take that skin and kind of place it here. So this was on the back of the ear, and we were not able to let this heal up secondarily because the skin cancer went all the way to the cartilage. So I want to protect the underlying structure, but we just took skin here from behind the ear. We were able to stitch that up in a line so that will heal as a nice line. And then we took that skin and put it right here on the back. For this patient, he got really lucky. No one will be able to ever see this, and he himself won't be able to see this, but this is how we do a skin graft. And then sometimes we have to do a complex closure called a skin flap. So in this patient, this was after his Mohs surgery. He had a basal cell. We cleared it, but this is not something that we can actually stitch up in a nice line like we did on the forehead. So we have to recruit tissue from nearby, and we try to recruit tissue in a way that we can hide the lines within the subunits or the shadows as much as we possibly can. And so this is called a skin flap, and afterwards the stitches were placed, and these stitches will come out in a week. So let's go through a real patient example. This is a patient of mine. She had a squamous cell carcinoma, and this was what it looked like on the day of her biopsy with her medical dermatologist. The medical dermatologist shaved this off. It came back as a squamous cell. She was then referred to me for surgery. On the day of the Mohs, you can see that there's still a little spot there, but even if you couldn't see anything visibly without doing Mohs, it's very tough to say if there's microscopically any skin cancer left. So in her case, we do visibly see something, but sometimes it's just a little pink scar. And this is what we call, it's on her vermilion edge, meaning some portion of the skin cancer is on the white portion of the lip, some portion is on the pink portion, and then of course on the border. So we have to take this location into account when we think about how are we going to put stitches. So finally, she had 2 layers done. So we had to go in twice to clear her skin cancer. And this was the defect, meaning the wound that was left after clear margins. And I went ahead and designed what's called a skin flap. So this is a special type of flap called a B to Y flap. And so histologically, this is not her particular skin cancer, but this is a representative sample of what it would look like under Mohs for a squamous cell carcinoma. And just to compare, this is what a basal cell looks like. These are the little basal cell tumors that are underneath the microscope. And this is kind of the normal structure of the skin. So we're looking for abnormal skin cancer cells under pathology. So back to our patient, this is right after I stitched her up. You can see she's pretty swollen. The skin looks pulled in tight. And most of the time, patients are like, oh my gosh, is this ever going to look better? And the answer is yes, it will look better. We decide she is not the best scarer. So we talked about the different options for scarring, and she decided that she wanted to also get laser revision right around suture removal. And I will discuss this right in this presentation. So this is at suture removal. It's still red and puffy, and we decided to do our first laser treatment for scar minimization at that time. And then this is 1 month after 2 laser treatments. You can see her scar has blended in nicely, and that even without makeup, you can't really see too much of the scar. And this is kind of our goal for most of our patients. Now, sometimes patients don't want to do lasers, and that's perfectly reasonable because lasers are not covered by insurance. And even without lasers, you can still get a reasonably good scar. So this is on the nose. It's a pretty deep area of involvement. And so we had to do what's called a skin flap. This was right after sutures were removed, so 7 days after surgery. And then after 3 months, you can see that scar is not really perceptible. So some patients do heal very, very nicely, and others don't heal the best. So we do have to individualize our approach to each patient. So when you're thinking about Mohs surgery, you want to choose a very qualified Mohs surgeon. Obviously, there are a lot of dermatologists who do Mohs surgery without being fellowship trained. And so you want to make sure that your Mohs surgeon is fellowship trained. You want to look for somebody who says they are part of the American College of Mohs Society. They have to be trained in dermatologic surgery, pathology, and reconstruction, and you can verify their credentials on mohscollege.org. Now let's talk about surgical excision. So surgical excision is a much quicker procedure. We can do it within 30 minutes. So what we do, let's say this is the skin cancer. We do have to take a margin around the skin cancer, and then we cut out a whole football shape around it. So the reason it's a football shape is because when we want to stitch circles into a line, you can imagine that when we try to close it, it's going to have little puckers on either edges. So we want to take out those puckers preemptively, and so we cut out this entire football shape. So often the length of the excision is about 3 times the width of your skin cancer plus the margin. This entire specimen is then sent to the dermatopathologist, so not a Mohs surgeon, but a different pathologist. And then we place stitches immediately, and we get the results of clear margins or not about a week later. And this has about 95% cure rate. So even though we're not visualizing the entire specimen, we actually still have pretty high cure rates for surgical excision. And after we cut it all out, we then have a line, and there's different ways of placing stitches, but usually when we have a surgical excision, we have a linear scar, and on the face, we usually put stitches on the top that need to be removed within 1 week. But occasionally on the trunk, extremities, I will put all the stitches underneath the skin, and this is called a subcuticular closure. This dissolves all on its own, so you don't have to come back to get it removed. So this was a melanoma I removed on the abdomen, and the tissue here is puckered, but all of that goes down within about 2 months. And on the face, though, we don't like to put subcuticular stitches. We do like to put stitches on the top so that you can have a nice approximated line here. So here's another scenario. This was a small little basal. We don't need to do Mohs for such a small basal on the back. And so we did a standard excision. The margins were clear, and the patient had this line, and this line will heal really nicely. So the reason we like to do dissolving subcuticular stitches on areas like the back is because when we do put stitches on the top, often you can get this railroad track mark on the trunk and extremities. You don't necessarily always get this on the face. So for different body parts, our surgical technique and suturing technique will differ to yield the best scar. There are always activity restrictions after surgery, and this was, I think, the hardest part, especially for me in San Diego. Our patients are very active, but you do want to avoid strenuous activity for about 2 to 3 weeks after surgery. And this is for 3 reasons. One, we want to decrease the risk of what's called a hematoma, which is a collection of blood underneath the stitches. We also want to decrease the risk of stitches popping open. This is called dehiscence. And of course, the more active you are, especially if you're hiking and doing all of these things and your surgery, let's say, is on the leg, you're going to have a higher risk of infection. We also want to avoid submerging the wound in pools, baths, jacuzzis, oceans for a much longer period of time, again, for infection risk. And day-to-day activities and gentle walking, I usually tell my patients it's okay as long as you're not too active. And all of this is because just because we're putting stitches in doesn't mean the wound is healed immediately. Even at 2 weeks after surgery, the strength of the scar is only 5 to 8%. So it's really easy to pop it open. Now, scarring. This is the most common question. So lots of things you can do to minimize the scar. Number one, you want to do the wound care as recommended by your surgeon. Wounds do not need oxygen. They don't need to breathe. They actually heal best if they're kept clean, moist, and covered. And we like Vaseline or Aquaphor ointment to keep it moist. We do not like Neosporin because a lot of patients can get a rash to it. Healing also depends on the size and location. So legs heal very slowly. They also heal the worst in terms of scar. And then the back, chest, shoulders also scar a lot worse because those areas of the body are tighter, thicker. We have a lot of movement from those areas. And so they will scar worse than, let's say, the face or the neck. Full scars take about 6 to 12 months to really do its thing, so you have to be pretty patient. And initially, the scar will be red, swollen, firm, thick, indurated, all these different qualities, but then over time, it becomes softer and fades over time. If we want to help the scarring, I usually recommend silicone scar sheets. These you can get from Amazon, CVS, Walgreens, and you would start those usually 2 weeks after surgery. They look like little Band-Aids, so you just cut them to size and put them on the surgical scar. You want to use it for at least 1 month, but ideally I recommend 3 months. You can also use silicone scar gel if you have an adhesive allergy. Sun protection is important for scars as well because sun exposure will either make the scar redder or browner. And smoking is one of the worst things for scarring. It can slow healing by about 30 to 50%, and it can really cause bad scars. Now, moving on, I often will do laser treatment for scars. So I'll have a discussion with my patient on the day of surgery. If they're incredibly scar conscious, then we would talk about doing lasers pretty soon after surgery. So usually 1 to 2 days, 1 to 2 weeks after surgery, which coincides with removal of the stitches. We have 2 different lasers that we mainly use, or 2 types. One is called the PDL or KTP, which helps to reduce the redness. And then the other one is called a fractional laser that helps to smooth the texture. Often multiple treatments are needed, and so I'll say about an average of 2 or 3 treatments spaced 4 to 6 weeks apart. And scar revision, even though it's caused by a skin cancer, is really considered cosmetic. Unfortunately, it is not covered by insurance. So I don't think my videos will play, but this is a laser we use in our clinic for the redness. It's called XLV. And then this is a fractional erbium laser. It's creating channels into the scar and helping to cause collagen remodeling so that we can convert the scar collagen to normal collagen. And finally, I think Dr. Lin briefly mentioned this, but there is some evidence to show that yearly laser resurfacing can really decrease the risk of skin cancers by 40% in patients with a history of skin cancer. And this was a study done at Harvard back in 2023. So I have a lot of my patients who have had many Mohs surgeries on their face who come in for their yearly resurfacing treatment. It is not covered by insurance, unfortunately, but it can really be beneficial to decrease the risk of skin cancers in addition to a lot of the other things that you can do. So finally, I just wanted to discuss this patient. She's had actually several Mohs surgeries, kind of on her face. She decided to come in for laser resurfacing, and after one treatment, you can kind of see she looks a lot better. But I wanted to point out, these are the little precancers, actinic keratoses, and these can have a risk of turning into squamous cell carcinomas. And so if we can decrease the burden of sun damage, we can decrease the risk of skin cancers. So, setting expectations, I always let my patients know all surgeries leave a scar. No such thing as scarless surgery, but the goal is to blend it in as much as we possibly can. Healing is really variable. I cannot predict how you would scar because it varies by the body area, tension, individual biology. Some patients just inherently scar better than others. So it really is a partnership between me as the surgeon and the patient for the best outcomes. So take-home messages, skin cancer is a very treatable cancer when it's caught early and treated appropriately. Mohs surgery offers a best cure rate with tissue preservation. Make sure you choose a fellowship-trained Mohs surgeon. No such thing as scarless surgeries, but scars can be minimized with proper care, silicone scar strips, and lasers. So thank you so much, and please enjoy the rest of the webinar.
Thank you so much, Dr. Cannon. That was great. From your pictures, I can tell that you do really nice work, and that's so great for your patients. Now we are going to head into our Q&A. And if I could ask our speakers to put on their video. And I already see several really great questions in the chat that I will direct to some of you. I'm going to combine two questions into one, and this one I will direct to Dr. Lin. So Dr. Lin, other than the sun, are there other sources of UVC that we should be aware of?
No, the only other area where we see UVC is in labs. They use UVC to destroy microorganisms, like when they're working with cells, but I think majority of people don't get exposed to that. But I do think about plane flights. So the higher the altitude you are, technically, the more UVC you're getting. And there have been studies suggesting that pilots and flight attendants might have a slightly increased risk of skin cancer. It's been hard to prove for sure, but and again, it's something I think you can't really protect against. So that would be the only other time I think about UVC.
And then another question on UV that I want to direct to you, Dr. Lin, is are there UV rays in the dryers at the nail salon?
So it's a great question and one that comes up a lot. So certain, I'm forgetting the type of nail where you have to, so anyone feel free to jump in when you have to bond it. Is it there's a tiny amount of UV in one of
Gel
the,
manicures.
oh, gel manicures. Yes, I think so. So they have you put your fingers under the light and for bonding. There have been studies showing that the UV there is so small that it probably doesn't increase risk.
I actually wondered about that as well, so thank you. I'd like to direct the next question to Dr. Shi. I have had several warts over the years. Is there any connection between warts and skin cancers?
Yeah, that's a good question. So the short answer is no. There's no, link with common warts and skin cancer. So, I mentioned briefly in my presentation about a very specific situation, but for most patients who do have warts, warts are very common. So the typical warts that you're going to get on, your hands, your feet, your trunk, there's really no link with skin cancer development. So you really don't have to worry. In certain patients, for instance, if you have a weak immune system, that could increase your risk. And in certain areas, so like I mentioned, the genital area, to start off with, there are over 200 types of HPV virus, which can cause warts. And so there's a lot of different types of HPV. In the genital area, there are, multiple types of HPV that can present in that area. And so those can sometimes cause the common genital warts that you can get in those areas. And then, they can be associated with things like cervical cancer. And in very, specific and rare instances, sometimes they can present with very early types of squamous cell cancer in that area. So that SCC in situ type that I talked about. So there are certain situations, but for the vast majority of people who have, normal run-of-the-mill warts, you don't have to worry. Um, that being said, I should note, that sometimes what looks like a wart could potentially be a skin cancer. So if there's anything new, and again, anything that's changing or growing rapidly, just, let your dermatologist know because they'll be able to tell, is this a wart or is this a skin cancer?
Thank you, Dr. Shi. That was very helpful. I'm going to pose the next question to Dr. Cannon. I've struggled with infections post biopsies. What are the best cleaning practices at home to keep stitches healthy?
Yeah, no, great question. So usually you want to so biopsies you can actually clean with just soap and water, and antibacterial soap you can use, and just make sure that your hands are clean. You can put gloves on first. So clean up with soap and water, and then you'll want to put Vaseline or Aquaphor ointment. A major mistake that patients make is that you'll use ointment that you've already opened and had your hands touch and kind of get all over. So you want to get a brand new tube. Make sure you use a Q-tip to apply the Vaseline ointment, and then keep it covered with the Band-Aid until it completely heals. And you'll want to do wound care kind of every single day and keep it covered until it heals, which usually will take a lot longer than patients think. It usually takes about 2-3 weeks to heal from a biopsy fully.
That was very informative. I did not know that either. So I'm learning with everyone else. I would like to pose the next question to Dr. Lin. I'm always confused about sunscreen. What makes them the most effective? Should I be concerned at all about the possible effect of these chemicals on my skin?
So we could spend a whole 20-minute talk on sunscreen. There have been a lot of controversies on it over the years. The big one that came out, I think 5 to 7 years ago, was whether chemical sunscreens were bad for us. And that was because the chemicals do cross into your blood. So that's been demonstrated. The significance of that is not clear. A lot of the chemicals that are used in sunscreen have been used even longer in cosmetic products. So they've been around, many of them, decades, without clear undue cause. The ones that were thought to be concerning for reefs have already been removed from sunscreens. So that being said, I think when you're in Hawaii and several other areas, they ask you to only use physical blocking sunscreens. If I have a patient who is at all concerned about chemical exposure, then I do direct them to physical sunscreens. In general, though, my recommendation is to use something that you're going to use. And the challenge with the physical blocking sunscreens is that they tend to be very white. They're a little stickier. So if that means someone is going to avoid putting on sunscreen, then I don't think that's the best solution. They do come now micronized nanoparticles, so they tend to be a lot smoother than they used to be. But the physical blocking sunscreens, for them to work, as you remember, they're reflecting light. You generally want to see a little whiteness because that's an indication that it's doing its job. And then for my really high risk patients, I don't care. I want them to have sunscreen on. I think the risk of chemical sunscreens at this point is not clear and probably not a major issue. Like if you're so concerned about chemicals, and we shouldn't be using any plastic. There are many other sources, unfortunately, of chemicals in our day-to-day lives.
And on a related question, Dr. Lin, are chapsticks with sunscreen beneficial?
Yeah, I do find them useful. I do find that to be an area that burns frequently. So for long exposures in sun and water, where you're stripping away your natural top layer of dead skin that protects you, then yeah, I do think it's useful.
Dr. Dang, I will pose the next question to you. There are apps out there that offer to diagnose skin cancer. Do you have any confidence in this technology?
Yeah, so a challenging question, a great question. I will say that at present, I think that the usefulness of technologies like this is not reliable enough. So I'm sure that there are certainly cases where, like, when the answer is kind of obvious and enough that a photograph may be able to be informative enough for like machine learning or AI to be able to detect something like that, you may be able to get an answer. But ultimately, I think a lot of the times we have cases that really just need the judgment in person by a dermatologist who's able to examine things really thoroughly in order to make a decision about whether to proceed with biopsy or further evaluation or other treatment steps. So I think that there may be a role for them to play in the future, but right now, I don't think it is enough to take the place of a trained dermatologist.
I just want to comment also on that question that they are not under any FDA regulation, those apps, so they don't have to clear or demonstrate a certain, you know, specificity in order to be out there. So to take that with a grain of salt, and that very few of those companies have consulted a dermatologist when they were making their app.
The other add-on too is that by the time you're considering whether something should be evaluated or not, if the next step is going to end up being a biopsy or further management, then you would want to be evaluated in an office anyway.
Those are all excellent points. Thank you. I'm going to pose the next question to Dr. Shi. Getting in to see my dermatologist can be really difficult. Is it okay to see the clinic's PA instead?
We know that it's really challenging sometimes to get in. I know the clinics are always busy. Access is definitely an issue. And so, first off, I think if there is a concern that you have, do try to make your dermatology office aware. We sometimes get a lot of calls and messages every single day, so sometimes it doesn't come to us right away. So I would encourage you to even reach back out, multiple times, because if we don't know that you have a concern, then we're just not aware and we can't help you. But that being said, I think it's absolutely fine to see a PA or a nurse practitioner if you have a specific spot that you're worried about. Most of the time, the only way that we're going to be able to know for sure what's going on is probably to do a biopsy. And, our PAs and nurse practitioners are well equipped to do that. And so if that's the only person that you can get in to see right away, just get that appointment and have them take a look and potentially do a biopsy to get the answer.
Thank you so much, Dr. Shi. I'm going to pose the next question to everyone, so please feel free to chime in. If a melanoma presents itself in multiple lesions at one point in time, does this always suggest metastasis, or is it just as likely that these were isolated local instances? Maybe I'll start with Dr. Dang.
I'm sorry, I kind of cut out there. Can you repeat that?
If a melanoma presents itself in multiple lesions at one point in time, does this always suggest metastasis, or is it just as likely that these were isolated local instances?
Yeah, I think a challenging question that would probably need to be individualized. So I'm sure that there are certainly cases where, actually, I've had cases where a patient will have multiple independent melanomas at the same time, where we are relatively confident that they are not related to one another. So they might be on two areas of the back, but they're both relatively low risk. So we don't think one spread to the other location. There are ways that we can look under the microscope to kind of detect whether we think a skin cancer may be spreading or invading, or sometimes there are signs that it has come from another spot. So I think that the short answer is like maybe. There are certainly times where you can have two at the same time, and there are certainly times where you can have related types of lesions at the same time. But it just requires a careful evaluation by a dermatologist to be able to tell how much risk we're really facing.
Thank you so much, Dr. Lin. Dr. Shi, do you have anything to add?
Yeah, I just want to, I guess, double up on what Dr. Dang talked about. It's kind of the melanoma part is sort of beyond the scope of our seminar today, but um, just like Dr. Dang said, you can have multiple low risk melanoma in situs on a person at the same time. But in general, if you have multiple nodules that all come up as melanoma, then that is more concerning for the type of melanoma that can spread. So you can't make any assumptions like Dr. Dang said, and you need to get evaluated.
And then there's another question that I will pose to Dr. Cannon. I've developed hives where adhesive is used to keep gauze on post-biopsy. My dermatologist started using Hypafix. Is a bit better. Are the other ways to protect without causing rashes?
Yeah, so we have a lot of patients who have an adhesive allergy where they'll develop a contact dermatitis to the adhesive. The challenge after surgery is that we want a pressure dressing for 48 hours post-surgically so that you don't develop bleeding or bleed, excessively, especially if you're on blood thinners. So if we're able to, we can try wrapping the area. So for example, if it's on the extremities, even the scalp, we can actually use Coban wrap or Ace wrap to be able to put some pressure. Hypafix still has adhesive, right? Because it's tape. Whether some patients will react less to Hypafix versus other types of bandage adhesives. So we try our best, but if you're allergic to a lot of different bandages, then we can't put a wrap, then I will still take the decreasing the bleeding risk. So we will maybe put a pressure dressing for 24 hours, for example, instead of 48 hours that you can then take off. And then the less the contact, sometimes the irritation isn't as severe.
Thank you for that, Dr. Cannon. It looks like we have answered all the questions and they were all very excellent. So thank you so much for listening so intently. We are now going to go to our break and we will reconvene at 10:45 for our fourth speaker. Thank you all. Hello, everyone. Welcome back. I hope everyone had a nice break. I'm going to introduce our fourth speaker, Dr. Timothy Dang. Dr. Timothy Dang is a dermatologist here at UC San Diego, and he is also the director of oncodermatology here. And he will be talking to us about non-surgical management for low-risk skin cancers. Tim, take it away.
Thank you for the kind introduction. Let me get my slides up here. All right, we should be good to go. Okay, so I have the pleasure of talking about non-surgical management for low-risk skin cancers today. So let's go ahead and get started. What I'm hoping for is, here's our learning objectives. This is what we're going to learn in my little session here. We're going to review again what types of skin cancers are considered low risk. We'll talk about scenarios where these non-surgical treatments actually make sense. We'll identify the different types of non-surgical treatments. We'll talk about how we monitor for success in these areas, and then we will provide some real-world examples. So let's kind of review a little bit about what Dr. Shi had covered earlier in terms of how we stratify skin cancers and how we define something as being low risk. So in general, basal cell cancer and squamous cell cancer, so BCC and SCC, are generally the lower risk skin cancer types relative to something like melanoma. But just as Dr. Shi had mentioned, we do have to consider other types of information related to these diagnoses. So we have to think about the size of the cancer, the location on the body, and the subtypes of the cancer. Not all skin cancers act the same. So there are certainly skin cancers that would be thought of as being higher risk, depending on these types of factors. And your dermatologist will be your guide based on that level of risk. They'll talk to you about the options that would be reasonable in your particular case. So let's go to low-risk basal cell cancer first. In general, smaller is better. So there's sort of an arbitrary cutoff, but less than half of a centimeter would be a reasonably small type of basal cell cancer. And the low-risk areas would be the trunk, so like the chest, the abdomen, the back, the arms, and then the legs sometimes too. Areas where we would be like, I'm not so happy about that one would be in more sensitive areas, for example, like the face, the neck, the genital area, etc. The subtypes that we're looking for here is the superficial type, so just sitting on the surface layer of the skin. But we also can consider nodular subtype to be relatively lower risk as well, compared to some of the high-risk skin types or high-risk basal cell types. For low-risk squamous cell, we think of also the same thing, that smaller is generally better. We want them to be in those same low-risk locations, the trunk, the arms, the legs. And the subtype that we're looking for here is in situ. So we want it to just be confined to that outermost, most superficial layer of the skin. So it's just sitting in the epidermis. It's not considered to be an invasive type of squamous cell. And then we're not going to focus too much on this today, but there are lower risk melanomas too. So you can also have a melanoma in situ, which is again confined to that outer layer of the skin. And in these cases, you may actually have a conversation with your dermatologist about some non-surgical options here too. But again, this is a less common scenario, and it's not something we're going to be focusing on today. So I really want to kind of focus on considering the whole person. So if you're going to come into our clinic and you have a diagnosis like this, what should we be thinking about when we're trying to figure out what we want to do for you? What's the best decision for you? We want to consider your age and your overall health. So for example, older patients who have other types of health priorities may not really want a surgical approach. We want to consider cosmetic outcome. So some patients would prefer to avoid a surgical scar. They may actually like the types of cosmetic outcome that could come with non-surgical treatment. And we want to think about function, downtime, recovery. So some patients may not want surgical recovery to interfere with their activities. Maybe they have a very active lifestyle or they have a lot of travel coming up. And so these are things that may impact their decision making. And then, of course, we want to think about your individual cost and your individual time. Some surgeries may take several hours. You might have to take time off of work for this. And some people may just prefer at-home treatment options for the feasibility and the effort that it takes. So this is a common scenario. My dermatologist took a biopsy of my back. It came back as a superficial basal cell carcinoma. This person really doesn't want to have a surgery. What are their options? What I want to emphasize here is that the decision about whether to treat a skin cancer should be a shared decision. And that decision should be a conversation between the patient and their dermatologist. What I'm emphasizing here is whether or not to treat. And then, of course, we're going to be discussing how to treat. But I want to actually make the emphasis here that choosing to treat something is also a decision that you want to make too. Because there are many reasonable scenarios where actually choosing not to treat something is a reasonable thing to do. So, oftentimes we think of this mantra of don't just stand there, do something. But what I want to do is flip that paradigm around and say, don't just do something. I want you to actually just stand there first, think about the reasonable options that we have, and then consider what actually makes the most sense for you. There's no need to necessarily rush into treatment oftentimes in these cases because these types of skin cancers being relatively low risk, we have time to think, to consider, to be thoughtful. We can walk. We don't have to run with these types of things. So let's talk about like the perfect candidate for non-surgical options here. So usually it's an older person. Usually they have a low risk skin cancer that's on the smaller size. I want it to be in a low risk area like the trunk or on the arm. I want a biopsy report that shows that the cancer appears to be removed in the available planes of section. So basically on that biopsy report, it looks like they got the whole thing or at least most of it. And then I want somebody who's like thinking about other health concerns that may be a greater priority, or maybe they're just too frail to tolerate more aggressive surgical types of treatments. And I want someone also who is not going to lose sleep if they're not definitively treating the skin cancer. So earlier, Dr. Cannon talked about the cure rate of Mohs surgery. And a cure rate of 99% is amazing if your priority is cure rate. But if your priority is considering some of these other factors, then it may be reasonable to not, quote, definitively treat the skin cancer or to treat it in a way that's not the highest cure rate. Because things that might have a lower cure rate may still give you other types of benefits. So let's get into those. The first thing that we can consider is the least amount of intervention. So you could simply just monitor. We also call this clinical surveillance. So this is particularly appealing when a biopsy report shows that the cancer appears to be removed completely. Now, there is some nuance to this because when a biopsy is read, they may not be looking at every single portion of the biopsy sample, but the pathologist is still going to do a reasonably good job of calling what they see. So if the pathologist is going to put their money down and say, yeah, it looks like it was removed, odds are it was probably removed. The other part of this too is that even if a specimen has one portion of it that is transected, so it's kind of cut through that portion, or if the biopsy report says that it is present at the periphery of the specimen or at the margin of the specimen, there's something notable here, which is that your body's inflammatory response, when that biopsy site is healing, that inflammatory response can sometimes actually treat any residual cancerous cells. Because remember, our bodies do an amazing job of getting rid of all of these things on a day-to-day basis. It's just when our body isn't quite able to counter the growth of some of these cells that they become problematic. But for the most part, our immune systems do an amazing job of stopping skin cancers from growing. It's just that sometimes some of these things can kind of break through. So what do we expect here? If you're just going to monitor or do clinical surveillance, you'll see your dermatologist as recommended, and that way they can routinely examine that site and identify whether the cancer has returned, and if it has returned, whether they would actually recommend treatment. So one of the good things about this is that just because we choose not to treat something here doesn't mean we're doing nothing. We're still going to be watching this slowly across time, and we can always make a decision at any other time to intervene. And then what would those interventions be? Well, we'll get into those now. So we can talk about topical treatments first. So you may have heard of this 5-fluorouracil, also known as Fudex. So this is a super common topical cream that we prescribe in our clinics. This is a cream that is preferentially absorbed by fast-growing cells, and it destroys the cells that absorb this cream. So essentially, it's like a topical chemotherapy, and it's relatively specific for precancerous and cancerous spots. Now, what can you expect if you do a course of Fudex for a superficial basal cell or a squamous cell in situ? Your dermatologist will likely recommend applying Fudex twice a day for 4 to 6 weeks, and this is something that you do at home. The expected reaction is that it'll get red, it'll get tender, you might get some crusting, you might get some discomfort in the area, and you're going to want to keep this area well protected from the sun. And then after that inflammatory response, you'll get a nice healing process across a couple of weeks, and then hopefully normal, healthy skin comes in to replace that cancerous, damaged skin. When this is done perfectly, when you apply it twice a day, as directed, 4 to 6 weeks at home, the cure rate can be up to 90%. It's usually quoted as like 80 to 90%, which again is not 99%. So that means that out of 10 people who do this, there still may be 1 or 2 people who don't have a perfect response. But for most people, a cure rate of 80 to 90% is still a very good probability. So keep that in mind. There's another topical treatment called imiquimod or Aldera. Many dermatologists favor using this. It's a topical cream that activates your immune system. So basically, it's like painting a target. You put the imiquimod on the biopsy site, and it calls your immune system into that biopsy site. It calls those immune cells into the cancer and attacks any remaining cells there. So it'll attack any precancerous cells, any cancerous cells, with the idea of kind of cleaning up any residual that is there. So what do you expect with this? They come in these tiny little packets, which is a little annoying, but that's what we have to work with. And the course here is usually 5 days a week for 4 to 6 weeks, also at home. You are going to expect the same type of redness, tenderness, crusting, discomfort. And then one notable thing here, I mentioned before that this was designed to enhance your immune system. Sometimes if that immune boost is really, really significant, it can actually give you like the sense that you have a flu or a cold. You will also want to keep this area well protected from the sun, and the cure rate here is probably a little bit better than the Fudex or that 5-fluorouracil, but I still quote it as being like 80 to 90% effective. Beyond topicals, what do we have? So there's something called an EDNC, which stands for electrodesiccation and curettage. EDNC is a procedure. So this is an in-office procedure that can be done by most dermatologists. It's about 15 minutes, so it's like a regular routine visit, which notably is shorter than having a full excision or a full Mohs procedure. Now, what to expect in this? Well, the area is going to be numbed just like they did in the original biopsy. So there's a pinch and a burn of that numbing medication, that lidocaine. And then the dermatologist will use a sharp tool called a curette to kind of scrape away at that lesion. And interestingly, like as dermatologists, we're really trained in trying to use our senses to figure out what we're doing. And we can actually feel and hear when we're scraping away that cancer. So like we can actually detect when we've gotten to the right level of scraping. Beyond the scraping, we also use an electric needle tip to burn the surface of the lesion. And then we repeat this 3 times in a row in the office. So at that same visit, you're going to get a scrape and a burn, a scrape and a burn, and then a scrape and a burn. And then after that, you are expected to have a charred scab at that site. And that usually heals within a few weeks with just basic wound care. The scar is usually flat. Sometimes it can be slightly discolored compared to the surrounding skin, but usually the cosmetic outcome here is pretty good if your dermatologist is being kind of selective about the type of person who would be reasonable to receive an EDNC. And the cure rate here is a little bit better than those topicals, so quoted at about 95%, which means that out of 20 people who get this, there may be like one unlucky person who has a recurrence, but that means that 19 out of 20 people who get an EDNC are going to do perfectly fine. This is a video that I took of me doing part of an EDNC with one of my patients. So this is the burning part of that procedure. You're not going to see the scraping in this, but there's that electric needle tip that is used to just kind of like char the surface of this. And then this gets repeated 3 times with that scraping and burning. The ultimate outcome here is going to be that kind of charred scab that you see. Moving forward, so there's also cryotherapy, liquid nitrogen, and many of you are probably familiar with this. This is something that is used to treat many precancers as well. But when we use this to treat low-risk skin cancers, it's a little bit different. So this is also considered to be an in-office procedure, a normal 15-minute visit with your dermatologist. And what happens here is that cancer is frozen with this super cold liquid nitrogen, and we freeze it for like 15 to 25 seconds at a time. And what we're expecting is that it'll take like a minute or more for it to thaw out. If we see that it takes less than a minute of thaw time, then we may repeat the procedure. I will say that I actually don't usually do this in my practice. It's just not something that I commonly perform unless a patient is specifically requesting it. Everyone has a different practice pattern, and so this may or may not be something that your individual dermatologist offers, but it is an option that is available. What to expect here? So you'll get pain during the procedure because we don't usually numb for this. You'll get a tender red area there, which heals within a few weeks, also with just basic wound care. And then usually the scar that you get there is flat. Sometimes it can be slightly different in color than the surrounding skin. And the cure rate here is sort of like that other procedure. It's about 95%. So basically these in-office procedures have a better cure rate than the topical, but not quite as good as doing like a full surgical approach. Now, here's a video that we have of that freezing. In this case, the dermatologist here has used this like kind of cone to kind of isolate where that freezing is going. They're going to freeze there continuously, and they'll make a ring around where that area of the skin cancer was. And what they're hoping for is that they have a full minute of thawing time after that. So the freeze time is going to be, again, like that 15 to 25 seconds, and then you're going to hope that it takes more than a minute for it to completely thaw out. And if that's the case, then you'll consider it to have been treated successfully. Then, of course, after this, your dermatologist is going to be monitoring across time too, which we'll talk about sort of toward the end of my slides here. Moving on to other approaches. So this is something called PDT, or photodynamic therapy, or light therapy. So this is also an in-office procedure, but just like some of the other options, it may not necessarily be available at every office location. So you may have to specifically ask your dermatologist about the non-surgical options that they would offer for you. In this procedure, the dermatologist would apply a topical liquid called a photosensitizer, and they put that liquid where that cancer was, and it increases the sensitivity to the specific type of light that they're using to treat. Then that cancer is irradiated by that specific wavelength of light. So it's sort of like painting the target and then shining that light there to destroy the cancerous cells. Side effects here, you can have some prolonged skin sensitivity after the application of that sensitizer. It can be a little uncomfortable. You'll get a tender red area, and it should heal within a few weeks with basic wound care. Usually, the cosmetic outcome of this is pretty good. It actually is one of the better cosmetic outcomes, but the cure rate here is also not amazing. So cure rate 70 to 80%. Now, again, 70 to 80% is not 90%, it's not 95%, it's not 99%, but this is still pretty good. So for some people, they would say, for every 5 people that are treated, only one of them has to come back for something more. Like, I'll take those odds. So for the right person, this may be a reasonable decision that they would make with their dermatologist. And then we'll move on to things that we also could offer, but are less commonly used. So this is sort of the new kid on the block. We have laser therapy that can be used to treat low-risk skin cancers. Also an in-office procedure. This would be something that requires consultation with a specific dermatologist who performs laser procedures. Now, this is not something that is as commonly used as many of these other techniques. It is something that is performed at UC San Diego. A specific type of laser is used to destroy those cancerous cells. You can get some mild procedural pain. You'll get a tender red area that you will be instructed on how to take care of with basic wound care. And again, the cosmetic outcome here in this case is also excellent. I don't have numbers to quote for the cure rate here. It's quite promising, but I think that we just need more studies to kind of quantify this and compare it to other types of options too. But this is something that may be very reasonable for somebody, especially if they already have experience receiving laser therapies. They may have a relationship with a laser dermatologist, and they may have the inclination to do this because of that excellent cosmetic outcome and kind of being on that like bleeding edge of the new technology. And then lastly, this is something that we talk about in many cases, and Dr. Park will likely talk about this in non-surgical management for higher risk skin cancers. But sometimes we use like full-on radiation. So this is performed by our colleagues in radiation oncology. It would require a separate consultation with them. And with these types of therapies, they use very precise beams of high energy radiation, and they destroy the cancer. But what do you expect here? The treatments can be a little prolonged. So sometimes you need to have multiple treatments on consecutive weekdays for a few weeks. And sometimes they can change or modify the treatment regimen and do it just a few times a week for even a shorter amount of time. You'll get a tender red area there that was irradiated, and of course, they'll teach you how to take care of it. And you'll also have an excellent cosmetic outcome here with a very, very high cure rate. But I think that the main issue here is that it just requires that consultation and coming in, and it may be a kind of high intensity in the office type of thing, even though it's a non-surgical way to achieve an excellent cure rate. So how do we monitor these things long term? Let's say that you choose to do a non-surgical option. What is your dermatologist going to do? Well, most of the time, if you've had a recent skin cancer, you're going to end up seeing your dermatologist every 6 months anyway. And so you're going to be in on a regular basis. And in those visits, your dermatologist is going to be monitoring these old cancer sites for clinical remission. They want to see if it's been successfully treated or if the cancer has come back. So no matter what you end up choosing, whether it's surveillance or cryotherapy or topicals at home or radiation, you're still going to have that relationship with your dermatologist where they'll be monitoring to make sure that you are in that 99% cure rate or in that 95% cure rate. We want to make sure that you're in that majority of people who are doing really well with this, not in that very small minority of people who don't get the effective cure from these non-surgical treatments. And then I want to end on some real world examples here. So I have three examples of folks who may kind of sound like people you know. So Mr. Weiler is a 55-year-old man, and he has a squamous cell carcinoma in situ, so low risk, of relatively small size, 0.6 centimeters, on the right forearm, so a low risk location. He's an avid weightlifter, and he does not want any procedure with stitches. And the reason for this is because the last time he had stitches on his shoulder, one of them popped, and it led to this like slow healing open wound, and he just really wasn't happy with it. It stopped him from working out, and he just didn't have a good time with it. He really wants to emphasize a high cure rate, but he does not want to go into the office multiple times, and he really doesn't care about the overall look or color of scars. He just wants to be active just like he always is. So what are his reasonable options here? Well, he could do at-home therapy, so he could use any of those topicals, or he could do that one-time in-office procedure, either that electrodesiccation and curettage, ED&C, or cryotherapy. Neither of these things are likely to interfere with his physical activity. And in contrast, if he did any of the other options, the cure rate of that photodynamic therapy may be too low for him. And he doesn't really want to have the idea of going in to have a consultation with a laser dermatologist or going in multiple times for radiation. So these are not things that he wanted. Case number 2 here. So Mrs. Penn, she's on the older side. She's 95 years old. She has a superficial basal cell carcinoma that's 1 centimeter in size. So this one's a little bit bigger, and it's on the upper chest, which is technically a lower risk area. Now, sadly, she has multiple heart issues. So she's been in and out of the hospital a lot, and she's been really prioritizing that part of her health. Her skin is important to her, but she really wants to emphasize all these other health aspects too. So she wants to avoid coming into the office as much as possible. Transportation from home is really, really challenging for her. So what are her reasonable options? Well, she may make a decision with her dermatologist to simply monitor. If we think that that skin cancer is relatively low risk, we don't think it's going to really do harm for her. To put it bluntly, she's probably going to die with it as opposed to from it. So the question is like whether it will be problematic or bothersome for her, and it's likely not going to be problematic for her. So she may choose to monitor, or she may want to do just topical therapies at home. Any of these other things, it would require an in-office type of procedure, would be an extra visit for her. So she's going to choose not to do those things. And then lastly, we have Miss Dennison. So she's 45 and she has a superficial basal cell and it's pretty small, but it's on the cheek. So technically this is not in a low risk area, but she works in a customer facing job and she wants the best possible option that prioritizes cosmetic outcome and cure rate. So she's giving us kind of a tall order here, but we can work with her. She's willing to come in as often as needed and she's willing to take time off of work to achieve this outcome. So what are her reasonable options here? We could do topicals, again, that cure rate being 80 to 90%, or we could have her have a consultation with our laser dermatology colleagues or our radiation oncology colleagues. And she may like that as an option just because it's going to leave a very good cosmetic outcome and they have a relatively good cure rate as well. She does not want things like cryotherapy. She does not want things like ED&C, nor would we recommend doing that kind of scraping and burning procedure on the face anyway. But for this particular person, a middle-aged woman with a relatively small basal cell, we can certainly talk about options that are not surgical that may, excuse me, that may have a good balance between cure rate and cosmetic outcome. Lastly, I have just 2 summary slides. I will not be doubling down on the information presented here, but these will be made available after the fact. So I'll just kind of linger here for a moment, and then I'll go to the next slide, which is the summary of the other options that we have as well. So that way you have them for posterity. But I hope that this was informative and kind of a whirlwind tour of the non-surgical options we have for low-risk skin cancers. If I could leave you with a takeaway point, it's that have a conversation, right? Everything is worth at least having a conversation. I think in these cases, if you want to be thoughtful about the options ahead of you, there may be times where there is one clear best option. And if that's the case, your dermatologist will tell you that, hey, we recommend a surgical cure for this. But if there's a time where there are reasonable non-surgical options and you want to talk about those options, have that conversation. We're always happy to help.
Thank you so much, Dr. Dang. That was really great. Learned a lot of different strategies that are different from what I will be talking about. So my name is Sue Park. I'm a medical oncologist. I am not a dermatologist, so I'm the lone wolf here. I will be talking about non-surgical management for high-risk skin cancers. So let me go ahead and share my slide. Can everyone see that?
Yes.
Okay, great. So this is an outline of what we'll be discussing today. So I'm going to be talking about what is the definition of high risk? What does it actually mean? And then I'll also be discussing immunotherapy, which is actually the new frontier of cancer treatment. But I put new in quotations because we've actually had immunotherapy for over a decade now. I'm also going to talk about neoadjuvant therapy. Does treatment given before surgery improve outcomes? I'll also talk about treatment de-escalation. Can we do better with less treatment? And finally, I'll touch on some clinical trials to show you how we can really push skin cancer care forward. So what is a high-risk cancer? It's as my colleagues already alluded to, a high-risk skin cancer is a cancer that has increased risk of coming back. You may ask, well, coming back where? It could come back at the site that it was previously. It could come back in the lymph nodes that where the cancer was drains into, or unfortunately, in some patients, it comes back in an area of the body that was far away from where the cancer was. And when we think about how we define what makes a cancer high risk, there are a lot of features that we consider, and I listed 10 here. We look at, how big is the cancer? Where is the cancer? Some places are more high risk than others, that we've heard. When we look at it under the microscope, there are different subtypes of cancer that we can see for skin. How deep is the cancer? Has it spread to other areas like muscle or nearby bone? Is it growing fast? Has it already started to invade the nerve, as Dr. Shi mentioned? There's also something called lymphovascular invasion, and that means we can see cancer cells in a blood vessel or in a lymphatic vessel. And we also look at, is this a cancer that has already come back before? And there are also certain high-risk patient groups where any cancer in them is really considered high risk, such as patients that are on certain medications, like the solid organ transplant population. So typically we do surgery for high risk skin cancer. We can do Mohs, we can do, standard excision. And sometimes after the surgery, we follow this with radiation to try and lower the risk of the cancer coming back. But this paradigm is currently evolving in flux and it is changing. So surgery is right now still technically the standard of care. But like I said, this is rapidly evolving, and I would argue that perhaps it is not the standard of care right now, especially with how effective something called immunotherapy has been for skin cancer. And this is particularly true for squamous cell skin cancer or squamous cell carcinoma. So, you may ask, why would we want to avoid surgery? Well, there are several reasons. Just cutting it out seems easy enough. But with cutting, depending on where the tumor is, how large it is, how deep it is, we could cause significant disfigurement. And this is really important because a lot of these non-melanoma skin cancers happen on the head and neck. We could also cause impaired function. We have a lot of important nerves that run through our head and neck. And if one of those gets injured, you could have nerve palsy. And that means you might have trouble closing your eye. You might have trouble smiling. And sometimes some patients are not physically well enough, or they have too many medical problems that they are just not fit enough for surgery. And then, are we confident that we can remove all the cancer with surgery? Is it likely that surgery will improve outcomes? Because sometimes it's not. If we're not confident that we can get everything, it's not really good to leave cancer behind. So immunotherapy has really changed how we treat non-melanoma skin cancer. So a question that I get asked a lot is, what exactly is immunotherapy? So immunotherapy is either an intravenous, so it's given through the IV, or more recently, there are several companies that have put out subcutaneous drugs, so drugs that you can just inject in the fat layer of your skin, similar to an insulin injection. So these are either IV or subcutaneous drugs. They are not chemotherapy. And they are typically given every 3 to 6 weeks, depending on the drug. There are many of these drugs on the market now. And they work by allowing your immune system, specifically your T cells, to really detect the cancer cells and attack them. And this is why we call them immunotherapy, because it's using your own immune system. This type of treatment is really effective for cutaneous squamous cell carcinoma. We also use it for basal cell carcinoma in certain circumstances. And these medications are administered under the direction of a medical oncologist. So someone like myself. So I have lots of colleagues, including dermatology colleagues and surgical colleagues, who refer patients to me specifically to get this type of treatment. Before we dive into the immunotherapy data, I first want to review some key oncology terms. So neoadjuvant, that term means giving drug before surgery. The term adjuvant means giving drug after surgery. Definitive just means whatever you're doing is the primary treatment. So for example, when I say definitive radiation, that means I'm treating that skin cancer primarily with radiation. Locally advanced means that a cancer has spread to nearby tissues or lymph nodes, as opposed to the term metastatic. Metastatic means that the cancer has spread to other parts of the body that are far away from where the cancer first started. So in oncology, what we really like to do is we like to find a drug that works really well. And typically, these drugs first start out in patients that have cancer in multiple sites. They have metastatic disease. And when we find a drug to be really effective, we like to move it up earlier and earlier in the treatment paradigm to see if we can really improve outcomes for more patients. So in 2018, the immunotherapy cemiplimab was the first one that was approved for locally advanced and metastatic squamous cell skin cancer. And I just want to highlight how fast this field has changed. 1 year later, the company opened a phase 3 trial of adjuvant immunotherapy, adjuvant cemiplimab for high-risk squamous cell carcinoma. In 2020, there was a phase 2 study that opened of neoadjuvant cemiplimab for high-risk skin cancer. And so one is after surgery, one is before surgery. That trial, just 2 years later, was published in a really big journal showing really great outcomes. And then just last month, this year, the drug cemiplimab was actually approved by the FDA for adjuvant therapy for high-risk squamous cell skin cancer. And this is the study that first started in 2019, as you can see here. And right now, there is a phase 3 trial of neoadjuvant cemiplimab that is open that we currently have open here at UC San Diego. There are other drugs that are approved for squamous cell carcinoma, but they're in the advanced settings, and those are pembrolizumab and cosabelimab. So where do we go from here? So what does neoadjuvant therapy look like? So when I said the word neoadjuvant means before surgery, we just give this drug before surgery. And then we look at what the surgeon has taken out. We have a special doctor known as a pathologist who assesses the amount of cancer left over under the microscope. In the trial that this paradigm was studied in, where we gave the drug before surgery, 51% of the patients had a complete pathologic response, meaning that whenever the pathologist looked under the microscope, they saw no remaining cancer cells left, which means that the drug that we gave before surgery worked really well. And an additional 13% of patients had only 10% or less of cancer cells remaining, and that's still a really great outcome. So what does this mean for treatment right now? So after surgery, what do we do? So in this specific study, you can see that if you had no cancer cells that were seen under the microscope, that complete pathologic response, 60% of the patients were just watched. They did not have any additional therapy. And to date, they have not had the cancer come back. And remember, this is high-risk cancer. These cancers like to come back. 30% of the patients who had a major pathologic response, so those patients that had 10% or less of tumor left in the specimen, they also did pretty well, although the number is smaller here, but they did have one recurrence. But this patient had a pretty large tumor and had a large lymph node that was also involved. So perhaps that patient, just watching them may not have been appropriate. And so we're learning a lot about, which patients are right to just watch, which patients may need additional treatment after surgery. So then this begs the question, if you do have a complete pathologic response to neoadjuvant therapy, do you need radiation after the surgery? Probably not. But can we actually take this one step further? Can we avoid surgery? So that's the question. Can we treat patients with immunotherapy alone? Essentially, can we cure patients with immunotherapy alone? And there was actually a nice study done at the Cleveland Clinic not too long ago where all those patients got immunotherapy first. So most of the patients in that study got cemiplimab. There was about 15% that got pembrolizumab. These are all very similar drugs. And you only got surgery or radiation if your cancer got worse on the immune therapy. So this was a smaller study. It only had 36 patients. Like I said, most of them got cemiplimab, but the median number of infusions that these patients got, remember, these are either IV infusions or subcutaneous injections given about every 3 to 6 weeks, depending on what drug we use. The majority of the patients got about 13 infusions. That was the middle number. So that's about 10 months of treatment. And they assessed these patients by looking at CT scans or imaging. And there's a certain evaluation criteria called iRECIST. And this is just a way that we measure what we see on a scan for patients that have gotten immunotherapy. And they saw that with just immunotherapy alone, 42% of patients did not have the cancer come back. And so this is adding to our growing understanding and the growing concept of definitive immunotherapy. And remember, I said definitive means a primary treatment. The primary treatment here for these patients, if they respond, was just the immunotherapy alone. And this is something I actually tend to use a lot in my patients, but it's a decision where I take a lot of other factors into account. Can we also predict who can avoid surgery? So building upon the concept of definitive immunotherapy, can we be smarter about this? Can we actually predict these patients somehow? So this was actually a trial that was just published this year where patients got neoadjuvant therapy. And this time, the drug that was chosen here was pembrolizumab. They got 4 cycles of this, so about 3 months. And they defined a new response category for this particular trial called a clinical complete response. So this was defined by having either a complete metabolic response on a PET scan, meaning that the tumor on the PET scan no longer lit up after you got the immunotherapy, or you could have more conventional imaging like a CT scan or an MRI, and we didn't see any tumor left on that scan either. So some type of negative imaging combined with negative mapping biopsies. So mapping biopsies are just biopsies where the tumor once was to see if there's still cancer left. So if you had both of those criteria, negative imaging and negative mapping biopsies, you actually just got pembrolizumab. So you just got more immune therapy. If you did not meet those 2 criteria, then you were considered having a non-clinical complete response and you went to surgery. But these patients that had a clinical complete response, 48% of them had no cancer that came back, and it's been 18 months ongoing. That's really good. The question that I have is, could these patients have just been watched, with no additional therapy? And I think so, based on what we know from the other studies. But that was not an option in this trial. Everyone in this trial did get more immune therapy if they met this clinical criteria. So we are now bringing immune therapy into earlier spaces by injecting drug directly into the tumor, and the goal is to avoid surgery. And so this is a phase 3 trial that we have open here, and it's open at a lot of centers across the US. And the PI is Dr. Lin. She was our first speaker. And this is really for early stage squamous cell carcinoma. So anything that's about 1 to 2 centimeters. And it's a randomized study. So you either will get injections directly into the tumor of this immune therapy, or you will be randomized to surgery. And this trial is really trying to answer if injecting immune therapy directly into the tumor, can it work just as well as surgery as preventing the cancer from coming back in the future? Patients with solid organ transplant and allogeneic stem cell transplant for certain blood cancers, as we've heard from Dr. Shi, they're a very high-risk group. They typically are on strong immune suppressive medications, and they're on these medications to prevent graft rejection and to also prevent graft versus host disease. So this makes giving immune therapy to these patients really challenging because these patients kind of need to be immune suppressed because they have a graft. And so there is a trial that we have open here that's also open at a lot of other centers around the nation. This is the Arcticus trial, and this is specifically for patients that either have a solid organ transplant or a stem cell transplant that have a high risk recurrent locally advanced skin cancer, either a squamous cell, a basal cell, or Merkel. And this RP1 injection is actually an oncolytic virus that is injected directly into the tumor every 2 weeks. And we wanted to just make sure that this was safe and did it work. And so they recently reported out the outcomes for this study not too long ago. And so for the patients that had locally advanced squamous cell carcinoma, they actually saw that the cancer got smaller in almost 35% of patients. And considering that these patients could no longer get surgery, could no longer get radiation, their only option then is really chemotherapy because they cannot get IV immune therapy or subcutaneous immune therapy because of the risk of graft failure. This is really good numbers for this high-risk patient population. The disease control rate, meaning that the percentage of patients that either had their tumor get smaller or their tumor just stayed the same and did not get bigger, was 65%. And at 2 years, 61% of the patients still had an ongoing response. And none of these patients had any evidence of graft rejection. So lastly, can we use immune therapy for basal cell carcinoma? We heard a lot about this cancer too. Well, the drug cemiplimab is actually approved for locally advanced and metastatic basal cell carcinoma, and it obtained this approval in 2021. But this approval is only for patients that have been on hedgehog inhibitors. So hedgehog inhibitors are actually pills that target a specific pathway known as the hedgehog pathway. And to be able to get immune therapy for basal cell, you either had to have been on a hedgehog inhibitor and it stopped working, or you took the hedgehog inhibitor pills and they caused you to get really sick, you just could not tolerate them, or you were on them for 9 months and the cancer did not get any smaller. So those pills are not immune therapy or chemotherapy. They're actually called targeted therapy because they're working against a specific pathway. So when we give immune therapy in these patients, but they already had exposure to a hedgehog inhibitor, the objective response rate is only 31%. So only in 31% of patients does the tumor get smaller. And that is lower than what we see for squamous cell skin cancer. Recently, there's a study that actually looked at immune therapy first. So not second, not after hedgehog inhibitor therapy. And the objective response rate is much higher. It's 52%. So then, we ask ourselves now, similar to what we asked ourselves for squamous cell skin cancer, can we bring immune therapy into earlier lines for basal cell cancer? And so there was a small study done at the Cleveland Clinic. It was only 13 patients, but those patients got neoadjuvant and adjuvant pembrolizumab for patients that had high-risk basal cell carcinoma. So in this case, they got treatment, the drug before surgery, and they also got it after, neoadjuvant and adjuvant. And the complete pathologic response here was lower than what we see with squamous cell skin cancer. It was only 27%. But that gives us, something to work off of for future studies. And here at UC San Diego, we do have a phase 2 clinical trial open. It's called the NEON study. This is a trial for high-risk basal cell skin cancer, and it's using 2 different types of immune therapy. One is called Opdualag, which is 2 immune therapies combined into one bag, and the other is just looking at nivolumab alone. And it's really trying to leverage the observation that giving immune therapy first before exposure to hedgehog inhibitor has higher response rates for basal cell, but also that maybe the addition of a second immune agent, the Opdualag medicine, it might be more effective for basal cell skin cancer than a single agent alone, because in the tumor microenvironment of the basal cell, there's high expression of a molecule called LAG3. And relatlimab, which is part of Opdualag, is a LAG3 inhibitor. So we also want to see in this study if we can avoid surgery in certain patients who have a good response to immune therapy. And then we also want to see how durable those responses are, meaning that, does the cancer still stay away even after we stop treatment? So integrating immune therapy into your treatment plan is best done utilizing a multidisciplinary approach. I work with a lot of amazing physicians, and as a medical oncologist, I am often considered the quarterback for the team. Here we recently opened a multidisciplinary clinic where patients can see me and the surgeon at the same visit. And after the new year, we will also be including our radiation oncology colleague in this clinic as well. So key takeaways. Immune therapy right now is really transforming the way we treat non-melanoma skin cancer. And there are lots of ongoing trials investigating treatment de-escalation. Can we do better with less treatment? And also, it's really important to advocate to have us, medical oncology involved early in your care. We have access to new drugs, lots of trials, and that's how we move skin cancer care forward. So with that, I will stop sharing. And then I will turn it back over to Sam to talk to us about some resources that AIM at Skin Cancer has for us.
Hi, Sue. Thank you so much. Thank you, everybody, for the presentations. They were really very good. I learned things about that I didn't know before. So thank you for that. I thought they were really clear, and thank you for everybody who's joined us. So many people know me from AIM at Melanoma, but a couple of years ago, we formed AIM at Skin Cancer because we really found that there was a huge need for this patient population. So I'm going to take the time and talk to you about a lot of the resources that we have for non-melanoma skin cancer. Let's see, take it off. Perfect. There we go. So again, I am the president of AIM at Skin Cancer today. That's the hat I'm wearing. And so I'm going to share with you some of the resources that we have available for all of you. So I'm going to start off just like a sort of like a quick cheat sheet of some of the things that we have. Certainly our focus is the diagnosis, staging, and treatment options, and then helping to recognize and manage the side effects of treatment. And so the vast majority of the resources that you see listed here hopefully will provide just that for patients with non-melanoma skin cancer, their loved ones, and others who are looking to find information. So I'm going to highlight just a small number of the resources that we have. So the first one is our Ask a Skin Cancer Nurse. We are very fortunate that we have Krista Rubin, who works in an oncology clinic at one of the major cancer centers, and she's our skin cancer nurse. And so we're really here to help answer some of those general questions that you have about non-melanoma skin cancer when you're having some challenges and you're not in the clinic and you're looking for some questions, answers that you can then bring back to your provider. They do begin with things like prevention, symptoms and screening, pathology reports, and as I stated earlier, treatment options and other basic health topics during the journey. We also have a number of webinars that we host throughout the year. Actually, those are primarily done with Krista, where she brings in a guest from the outside. We recently, for Veterans Day, did Skin Cancer and Aging of Veterans, Unique Risks and Considerations. Our next one will be in January, The Rising Toll, Understanding the Surge in Skin Cancer Mortality. And then you can see the next two webinars that will be following in the weeks and months afterwards. We also provide a number of video guides, again, hosted by Krista. And there on the side, you'll see what some of these episodes are. They are just some short visual episodes for helping to understand the everyday things that come up when you are going through the non-melanoma skin cancer journey. And then, of course, it's so important to stay informed and protect your skin. If you have an opportunity, I would encourage you to use this QR code to access all of these resources. They are available for you 24/7. We can be reached via email. There's a toll-free number. And if you have any questions, either from this event or in the future, I want to encourage you to reach out to us. Again, thank you everyone for joining. I really appreciate it. Before I pass it on to the Q&A, I just want to let people know that after this event, If you have registered through the Zoom, you will receive a link to the presentations that you just enjoyed. You can share them with others, watch them again. And then, of course, they will be also memorialized on YouTube and our website. You will also receive a survey. I'd like to encourage you to complete it. We are always looking for new topics, feedback, etc., as we hold these events throughout the year. So again, thank you so much. And Sue, I'm going to pass it back to you.
Thank you so much, Sam. AIM at Skin Cancer has so many great resources, so we're so lucky to partner with you for this webinar. I'm going to pose the first question to Dr. Dang. What factors are considered in deciding whether to choose a surgical versus non-surgical procedure? What is the difference in scarring? How about allergic reactions to the topical treatments?
Sure, yeah. So these are complex scenarios, right? So there's no easy way to answer a question like this. Your dermatologist will end up considering many different factors, including what type of skin cancer is it? What subtype of skin cancer is it? So is it considered relatively low risk based off of what the pathologist sees under the microscope? What is the size? What is the other patient factors that may be a consideration, like their other health concerns? And then they may want to consider how the patient may want to use certain types of therapy. So whether it's an in-office therapy or an at-home therapy, really complex variables that go into the decision making. But I would say that it really just deserves a conversation with the dermatologist to see whether a specific skin cancer to the individual is considered low risk enough that non-surgical options could be considered. When we're thinking about those topical options and whether there's certain reactions to them, I think a lot of people perceive the expected reaction of topical treatment to be an allergic reaction because they get a lot of that kind of like redness, irritation, discomfort, but that is expected. That's actually a good thing. It tells us that we're getting a treatment response. There are relatively uncommon scenarios where people can get like a true allergy or a true intolerance to certain types of topicals, but it is certainly not a common thing. And ultimately, your dermatologist will try to kind of like thread the needle and make sure that they are dialing in exactly how much of the topical that you're going to need. So when we give an expectation of like, oh yeah, it's probably going to be 5 days a week for 4 to 6 weeks, they will walk you through the expectation in terms of what your skin should be looking like during that. And of course, if things are not to that expectation, then the curiosity is like whether like you had a really robust reaction to it or are not getting enough of a reaction to it or are getting an unexpected reaction to it. So I encourage people to just have a more thorough conversation with their individual treatment team about whether what is happening for them is expected or unexpected.
Thank you, Dr. Dang. That was very thorough. I will take the next question, and this also goes to highlight in the patient resources that AIM at Skin Cancer provides. So are there any clinical trials for squamous cell patients? Yes, at most, if not all academic centers, they should have some type of clinical trial for lots of skin cancers, melanoma, basal cell, squamous cell carcinoma. If you're at a community center, a lot of those physicians can refer you out. We have several here. Sometimes we don't have a clinical trial for everything, but if we have something for you, we will certainly talk to you about it. And AIM at Skin Cancer has great resources on helping connect you to clinical trials, because I know it can be very confusing. So I encourage you to reach out to them if you need assistance with that. Another really interesting question that can sometimes be difficult. I have rheumatoid arthritis and am immunosuppressed. Would immune therapy be a safe choice for my squamous cell tumor? So, a lot of patients right now have autoimmune disease, and those patients also develop cancer, especially skin cancer. And the problem is, if I give immune therapy to a patient that has an autoimmune disease, I'm kind of, boosting their immune system. They are at risk of having a flare of their autoimmune disease, or in this case, a flare of their rheumatoid arthritis. There are lots of different drugs right now for rheumatoid arthritis. There's JAK inhibitors, there's IL-6 inhibitors, there's lots of different things. Some of the medications for rheumatoid arthritis are more immunosuppressive than others. And so it is not an absolute contraindication. I have many patients that I give immune therapy to that have rheumatoid arthritis, but it requires me to work very closely with the rheumatologist to sometimes change their rheumatoid arthritis medicine to one where I feel like if I give the immunotherapy, I won't cause a flare, but I'm still able to elicit an immune response good enough to attack the tumor. And then the last question I
Oh,
see,
can I just jump in, Sue?
yeah, of
So
course.
I just want to mention, we often hear from patients who have side effects from these treatments, and we do have resources like side effect management sheets to help them. But I just want to really encourage everyone to talk to your providers. We're happy to assist. But, I know all of you are, I would think, are hearing from your provider that if you have any side effects or anything that you should, follow up with their office. And I know from many patients, you probably feel a bit maybe uncomfortable. You don't want to bother, your doctor's time, et cetera. But we always come back and stress, like, I know these doctors and their offices want to hear from you. And so if you are experiencing any of these things, I really want to encourage you to reach out to them and to, seek assistance.
No, I completely agree with that, Sam. I mean, one question that we have here is, if I need immune therapy, is there anything I can do in advance to reduce the side effects? There's not anything you can do prophylactically to reduce the side effects, but what you can do is, tell me if something is going on, tell me how you feel, get your blood work like you're supposed to, keep your appointments, because if I'm giving you this type of drug, I really want to keep a close eye to make sure it's working and also that it's not causing undue toxicity. With every procedure, even Mohs, as we heard from Dr. Cannon, everything has some type of risk-benefit profile. Another question I see is, I have just been diagnosed with basal cell skin cancer at my dermatologist's office. Should I ask for a consultation referral to an oncologist? I will pose this question to Dr. Shi.
So generally, in most cases, there's no need to see an oncologist for basal cell cancer. There are very, uncommon and specific situations where maybe that might be the case, but your dermatologist would let you know if that was going to be the case and will tell you that. So usually you don't need to see an oncologist if you have a basal cell cancer.
I will add to that because I am a medical oncologist. I think it is appropriate, like Dr. Shi mentioned, in certain instances, your dermatologist should be aware of when you should be referred. So for example, if you have a basal cell in a very sensitive area, like right by your, tear duct, that can be a difficult place to do surgery because your eye is right there. There are a lot of critical structures. Some patients have a basal cell that's pretty big, sometimes, more than 5-6 centimeters. And those types of basal cell cancers are sometimes even bigger than what you can see on the outside. And sometimes oncologists can help in that regard. If you have a tumor that is really hard and fixed and not moving, that may mean that it's deeper than you think. And that's another reason why you may want to see an oncologist. But your dermatologist should help you shepherd that. I see another question. My squamous cell skin cancer is very painful. Will that pain get better if the tumor shrinks? Typically, yes. So if you have a very large squamous cell skin cancer, and if your physician is starting you on immune therapy, the immune therapy works pretty fast. So typically, we will see responses even after the first infusion, if not the first, most definitely by the second. And that shrinkage is typically associated with improvement in pain. There are some patients after the first infusion, their tumor actually looks more red, more inflamed. The pain could get a little worse. This doesn't happen in everyone, and it doesn't mean that the tumor is necessarily not responding to the treatment. What can happen after the first dose is that all your immune cells, your immune system cells, are being recruited to the area of the tumor to attack the cancer. And that temporary recruitment of these immune cells can make the tumor look a little bit more inflamed. So when we see patients, we always examine their tumor. We want to see them with every cycle, and we take pictures to measure progress. I don't see any more questions in the chat. I'd like to ask Sam, do you have any final last words?
I don't, other than to say thank you so much for joining. Again, I greatly appreciate you guys being here today to give us all of this great information.
Thank you so much, everyone, and a big thank you to all of our speakers. Everyone was wonderful, and I also learned so much.